Good morning, everyone. I think we can begin. I just want to say welcome to everyone for being here this morning. I'm Ms. Sidlin Hambry. I'm a lecturer within the Department of Environmental Health here at the Nelson Mandela University. I just would like to welcome our honored guests for being here, my colleagues, as well as our environmental health students, which are in their final years. Also, I just want to extend my greetings and warm welcome to our honored guests from the university, Western Michigan University, and 12 of their final students. Also, our guest speakers from the Nelson Mandela Bay municipality, as well as from the Social Development Professions Department at the Nelson Mandela University as well. Also, we will have social work students from the Social Development Professions Department, as well as students from US Minnesota, which will be joining us later this afternoon when we do our group facilitated discussions, which will take place after lunch. So I hope you all feel very excited as I am today, because we will actually be touching on a number of topics relating not only to public health, but environmental health as well. So there is quite a familiar and popular saying by Nelson Mandela, and it's actually stated that knowledge is the most powerful weapon that you can use to change the world. So today is actually a great opportunity to take back knowledge, experiences as well from today's discussions and presentations, and also to build long-lasting relationships and to get to know each other as well. So I just quickly want to go through today's program and just to quickly run through it. So Professor Zoleka Soji, that's here today, which is our director of our school, within the Faculty of Health Sciences, will be doing an opening and welcoming, and everyone will then introduce themselves briefly. So you can just stand up and then just say your name, surname, and where you're from. Also, Dr. Robert Bensley, who is the Director of Public Health, that actually runs the public health program at Western Michigan University, will give a brief overview of the public health program offered at the university. And then my colleagues within the Department of Environmental Health will actually do today's chairing sessions. So we have Mr. Willem Michau that will be doing the first session, and Mrs. Cherise Brown will be sharing the second session. So they are actually both lecturers within the Department of Environmental Health, and Mr. Willem Michau specializes in food and meat hygiene and is also responsible for some of the food-related training workshops that he actually does. And then Mrs. Cherise Brown focuses on environmental management modules as well as the work integrated learning. And just to quickly, before we start, when we speak, because we are being recorded, so when each guest speaker speaks, you can just stand here, here's a block here in front, and we'll use the mic to speak. And then also, if you need the restroom, if you just head outside the door, if you see on the opposite side, there should be restrooms there for you to use. Okay, so I will now hand over to Professor Zoleka Soji that will do the welcoming and opening. Thanks.
Open the presentation. Sure, Sidlin is very formal. We have to stand at a particular point. I wanted to move around, but now she wants me to be stationed here. So good morning. Sure. Good morning. It must be a good morning. Ne? We have rain in Gqeberha, so you are in Gqeberha. Can we try and say Gqeberha? Gqeberha. Very difficult. So that is a challenge that I'm giving you by the end of today, if we can be able to say Gqeberha. Because that's who you are. So it's my great pleasure to welcome you all to the Faculty of Health Sciences. As you heard, I am Zoleka Soji. I am standing here in front of my former boss. Hey, Andre. So when I started working here at this university, I worked at student counseling as a social worker, and I worked as a coordinator for peer mentoring, as well as peer helping programs. And I was also offering some counseling for staff members. So I learned a lot in student counseling. And during those years, I also met Bob Bensley, who was a visiting scholar at the time. So for me, it's wonderful to see colleagues. I want to tell you who we are as a faculty. Yeah? So I point this side. So I want to say welcome to the Faculty of Health Sciences. In my language, which is in isiXhosa, we usually say wamkelekile, which is welcome. And in Afrikaans, they say welkom. I don't know in other languages how you say welcome. I wish I knew, because in South Africa, we used to have 11 official languages, but now we have 12 official languages because sign languages has been added as an official language, which is wonderful because it indicates diversity. So I want to say on behalf of our Dean, Executive Dean of Health Sciences, Professor Zukiswa Zingela, who is in Vienna currently, she's not here, as well as the Deputy Dean. And I know when they see this slide, they will want to scold me for using it because the university said we must use university branding. And I kind of liked the colors. I decided to go with this one. It's our canvas. It gives you who we are as a faculty in a nutshell. So in our faculty, we have about 11 disciplines. On this side, you will see our discipline. We have about 3 schools in our faculty. Our 3 schools, we have the School of Behavioral and Lifestyle Sciences, which consists of 5 departments. In these departments, we have dietetics. It's changed to human nutrition and dietetics. We have human movement sciences. Department of Environmental Health is one of the departments in our school. Social development professions, where we train social workers as well as psychology. It is in that school. The second school is School of Clinical Care and Medicinal Sciences, where the rest of the other disciplines like your EMC, Emergency Medical Care, Medical Lab Sciences, Pharmacy, as well Radiography and Nursing Sciences. And then the last school is the Medical School. And I do know that there are talks about having a department of public health. And at this point in time, we're unsure of whether it's going to be within the medical school or it is going to be part of some of the other schools. We're not sure, but there are talks about having the department or a section, a unit in terms of public health. Our vision is to co-create critically thinking health sciences graduates with transformative acting who change the world by being in service of society. At Mandela University, we position ourselves to be in service of society. We do that through engaging with international partners, like now we have international partner engagements. We also engage with communities as well, because for us it is through engaging with communities that we learn. It is through engaging with communities that we are able to find long-term solutions to problems that are facing our societies and our communities. As a university, we want to partner with communities. We don't claim to know everything. We are saying that we don't know. We come with that humility of saying we want to learn from communities. We want to co-create solutions with communities. And it is through listening and working with communities where we are able to co-create solutions with communities. So if you look at this, it's a very busy slide, I must say, but it gives you in a nutshell in terms of the different disciplines that we have, it also gives you in terms of our values as a faculty. And I want to highlight certain values here. Resilient wellness is key for us. And when we speak about that, we're not only looking at staff wellness, but we also look at student wellness. Social responsiveness is very important for us as a faculty, as well as professionalism and integrity. And then, lastly, where I want to point you is in terms of our strengths and assets. And if we're looking at our strengths and assets, in particular, I want to flag, it's there at the bottom, at this bottom, where we're saying that we are committed to, or we value engagement with our communities, and we want to ensure that we are socially responsive. And that for us is very important. The social responsiveness is very, very important. We want to ensure that the graduates that we are producing or creating are graduates who will be socially aware, graduates who understand the realities that they are facing in communities, graduates who will be globally connected. So for us, being able to engage with students who are coming from our international community so that we can learn, we can think together, we can share experiences is key, it's important. So it's very, very exciting for us that we will have opportunities so that we will be able to share. It's a pity that I will be missing the session where there's going to be group discussions, because I would have loved to hear those the engagements. So I want to say you are welcome. I want to say to you that I'm hoping that whatever is taking place today is going to lead to long-term partnerships, more than just us sitting in this room, that there's going to be more connections between students as a way of moving forward. Thank you so much.
Thank you so much to everyone and welcome. Nice to meet you. So before I introduce our next speaker, which is Dr. Robert Bensley from Western Michigan University, I just quickly want to take this opportunity just to also give a brief overview of Dr. Andre de Jager, because he was actually the real reason why we're actually here today, having this international collaboration. So thank you for connecting us. So I just quickly want to take this opportunity just to share a bit of information about you so that everyone gets to know you a little bit better. So Dr. Andre de Jager, so over the past 45 years, has worked as a registered counseling and educational psychologist. He is currently a research associate at Nelson Mandela University, and he also has developed competencies in professional areas over years of national and international experience as well. So these have centered on human development, research, and programming to promote holistic well-being of populations individually, in communities, and organizationally. So he's also worked and his work has also been recognized in South Africa as well as internationally. So over the past 20 years, he has supported our visitors from Western Michigan University. So thank you so much for connecting us, and let this be a nice, long-lasting relationship that we can build here today. So now our next presenter is Dr. Robert Bensley. So I just quickly want to just give a brief overview about Dr. Robert Bensley. So over the past 30 years, Dr. Bensley has been a professor and director of the public health program at Western Michigan University. He has numerous years of experience working with populations through grant-funded program development, implementation, evaluation, and research-related activities as well. He has served as a principal investigator on over 350 externally funded contracts, totaling over 21 million US dollars, most of which support the development and implementation of technology-based nutrition behavior change programming. And also Dr. Bensley loves to travel, having been to and lived in 35 countries. Wow, that's a lot of countries. And annually leads also a Western Michigan University travel study course exploring public health issues in South Africa as well. So we now kindly welcome our honored guest speaker, Dr. Robert Bensley, who will be giving us a brief overview of the public health program at Western Michigan University. Thank you. So you can just use the...
Thank you, Sidlin. I've got Luke coming up. Molo and Joini. Goeiemorgen. Or how we say it in the U.S., what's up? So, I want to thank you for having us here and being part of this. Thank you, Sidlin, for organizing this and working with Andre to get this together. And we are just excited to be here. We are excited to get to know your environmental health students, to work with them, social work, etc., to learn from you. And we have 12 public health students, as you saw. They all introduced themselves. And we are here to learn what public health action is taking place in South Africa. So what I would like to do is I would like to share what public health is from our perspective. As you had mentioned, you do not have a public health program yet. Zuleka, where did Zuleka go? She mentioned that. Okay, that you do not have a public health program yet. So I want to identify or share what we have in the U.S., and that might give you a better idea of possibly some avenues that could be incorporated here at NMU. So first of all, you may know this, you may not, but public health is a population health perspective. It's not individual health, but it's looking at the population. If you're looking at economics, you would think it in terms of macroeconomics versus microeconomics. So it's the big picture vision. And so our idea in public health is we are trying to improve the health of all populations, not one at a time, which we find in a lot of health sciences are really that focus on one individual at a time, which is important. But public health, we look at the long term from the population perspective. So looking at this in relation to some of the other areas in health sciences, we can look at it in terms of thinking about prevention. And we know that there are 3 levels of prevention. There's primary prevention, which means preventing problems from happening in the first place. There's secondary prevention, which is early diagnosis and treatment. And then there's tertiary prevention, which is when something has been a drastic issue has occurred and the individual needs long-term assistance. And so public health fits in that primary prevention mode. We are trying to prevent individuals from needing to seek medical care, from needing to seek nursing, social work, physical therapy, speech, blind vision, rehabilitation, cardiac rehabilitation. That's what public health tries to focus its efforts on. And if you, excuse me, if you look at it from this perspective, I don't know if I can move. There we go. We can look at how primary prevention, public health fits. Most of public health fits in primary prevention, but some fits in secondary prevention and tertiary, where our medical fields tend to be more secondary and our rehabilitation fields are in the tertiary. So what we look at from public health perspective is we think about it in the socio-ecological model, where the individual is in the center, surrounded by the family and the social circle, which is the intrapersonal, surrounded by the community and the institution and the organization, surrounded by the laws and policies, surrounded by the culture in which people live. Public health works on all of these angles, but we tend to look at the outside rings. That's where we focus our efforts. How can we develop policies or laws within the cultural context of populations that involve institutions and organizations which will energize the community, which have an ultimate impact on all individuals? Whereas in many other health sciences preventions, the center, the individual, is the focus, or maybe the family around the individual, or possibly the community. But public health looks at it from this outside ring going in forward. So that's part of that macro vision that we look at. Now at Western Michigan University, our public health students complete a 4-year program as part of their what we call undergraduate studies. So that's which your environmental health students here are in their undergraduate studies. So they will do 4 years. They don't do 3 years plus an honors year. They do 4 years. And in that, they learn these skills. So they learn how to assess community health programs. They learn how to plan developing community health programs. They know how to evaluate. They know how to develop health communication strategies for delivering messages across populations. They know how to look at advocating for passing laws that would protect populations, for how to energize communities to be able to have a grassroots effort to pass laws that protect that community. We look at behavior change. We look at how do we actually change behaviors in populations. We look at epidemiological issues, pandemics like COVID. We look at all of that. We look at the biostatistical methods of being able to evaluate and determine some of the problems that exist from that perspective. And we look at environmental health issues as well, because that fits within public health. And so really the 5 pillars of public health, if you're not familiar, is epidemiology, biostatistics, environmental health, health education and behavior, and health policy. So those are the 5 focus areas in which all public health programs focus in the U.S. We also have a graduate program, a master's degree program in public health. And one of our students, Magali, she did our 4-year bachelor program, undergraduate program, and now she is in our Masters of Public Health program, finishing that up as well. And so in the master's degree, we also focus on those 5 pillars, but then we go one step higher in relation to bigger and broader perspectives. And so a number of our students here in this group will eventually go on and could probably complete a Master's of Public Health. I know, raise your hand if that is in your, not next year, but somewhere down the line. So you can see that they all want that advanced training in public health. The way that public health is set up in the U.S. is that every individual is tied into what I think you would call a municipality public health program or department. We call those counties in the U.S. within every state, which would be like your provinces here. So we have counties within the states and within the nation. And so every individual is tied into somewhere being the responsibility of that public health department in all of those areas, epidemiology, all of that, etc. In addition, the public health departments expand out to include sanitation, healthy food, restaurant, check so that we don't have E. coli and different things passing through restaurants, and a number of other areas. Social work tends to tie into the public health departments as well. Environmental health may have their own department within the public health. That may be similar or different than here, but I'm just giving kind of a perspective of how it is operated in the U.S. So then at the state level, or the province level, like you would have here, we have a public health program that oversees all of the counties, and at the national level, our national public health program is called the Centers for Disease Control and Prevention, or CDC, and they are responsible for the health of our entire nation. So that is sort of an overview of public health. It gives you an idea of what our students are doing in public health, what they're studying. All of them have a specific concentration or topical area that they're interested in. Some are interested in substance use disorder. Some are interested in gun safety control. Some are interested in nutrition. So we have all of the different health issues. Each of the students have their specialty within public health. But they learn all of the assessment planning, evaluation skills, implementation to be able to step into those arenas and focus specifically on those issues. Did I get it right? Okay, thank you. Whew. So thank you for having us here. And that hopefully that was enough of an overview. Okay, thank you. Appreciate it.
Thank you so much, Dr. Robert Bentley. I just wanted to find out if there's any comments or questions before we move on. Nothing. Okay, thank you very much. Thank you. I'll now hand over to Mr. Willem Michau, who will be chairing the first session. Thank you so much.
Just set up Cheryl's story there, so. Yeah. Good morning, everybody. I noticed some of the students are still soft-spoken. You know, in this profession, you will learn eventually. My colleagues always need to turn down my volume wherever I am. So, but you will learn. People have to listen to us as well, Doctor, when we do those culture interactions to change the beliefs and so on of individuals and so forth. As indicated by my colleague, I'm a sort of dinosaur in this department for the last 30 years already. So I was as young as you when I started here. And this course with us started here around about 91, 92. That is the latest environmental health training institution in South Africa. We've got around about 6 of them, 6 or 7. I'm not 100% sure now, Cheryl. But we are very proud of our institution here. We are proud of the individuals that we deliver here, and of our department as well. And I'm so glad that you guys are here, that we can do a little bit comparisons and discussions afterwards to do that. I hope I also stand here as chairing the function in the first session, because I'm not a good picture here, you know. But in any case, I want to introduce you to our next presenter in this second session. A colleague of mine. We worked together for quite a while as well. She is Cheryl Swanepoel. You can see that attractive lady that sits there on my right-hand side. She will be embarrassed afterwards again because I'm saying things like that, because they mustn't allow me to come and stand here. I normally say things that they don't want me to say, but in any case. She's in this field of environmental health for a very long period, although it doesn't look like it. To consider that being she's an environmental health practitioner as well. That is how our profession actually also went through different names over the years. As part of who she is in this profession, not only what she does, much of that time has been spent teaching aspiring environmental health practitioners. Firstly in UJ, that's in Joburg. If you guys are familiar with this country, that's what they say, it's our golden city. But in any case, teaching remains a passion, and that is true. And although currently lecturing on communicable diseases and epidemiology is an interest field of environmental health, she was also lecturing quite a number of other modules over the years as well. Health and how best to facilitate learning and advance in this field. She's an expert there. Currently, she's our HOD, in other words, our boss, in the department, and lectures at the Nelson Mandela University in the Eastern Cape province. But she grew up in Gauteng province. It's not one, that's where Joburg is, that golden place. Places where I'm staying away. Listen, I've got a legit excuse as well. I'm originating from a neighboring country here, known as Namibia, from the Kalahari there. So please excuse my English if it's not very clear. That's a legit excuse for people originating from there to not be very good in English. But I'm trying my best. Now, Cheryl, in work there as an environmental health practitioner as well, in the Council of Springs, Equivaleni, that's the name I think now, with a special interest in preschools. I think her husband and she was running care centers as well in their days over there. And she was, in those days, she was academic in the University of Joburg at that stage, or Johannesburg. She is married with 2 sons, one new and lovely brand new not granddaughter, that's the one that she's wishing for, but she's got a daughter-in-law. One of her sons was married recently. She actually wanted this daughter-in-law to produce very quickly, to have this grandchild there as well, because she can't wait. And then she's got 2 cats as well, which is currently her children, because her children is out of house already. Well, Cheryl, will you please come and address us now on our degree that we offer here, the Bachelor of Environmental Health degree program offered at the Nelson Mandela University. Thank you.
Thank you, Willem. Thank you very much. I think when I'm told to stand on a spot and I've got a camera and a mic, I think I'm auditioning for idols, and I definitely won't make that. So thanks for the introduction. I think I'm going to just dive straight into it, so you already know. Is it not? Oh, okay. I wasn't going anywhere with it just yet, so I'll get the gist of it now, which goes where. So you've already heard we're part of the Faculty of Health Sciences within the School of Behavioral and Lifestyle Sciences. So I thought before I started looking at the actual course that we're offering here, and maybe it's just as well, because it's almost as if we were thinking along the same lines, is just to maybe speak a little bit about a really broad overview of our health system and public health in South Africa. So we in all different fields have got 3 levels of governance. So we've got our national departments, we've got provincial departments, as was mentioned already. So we've got 9 different provinces, and we've got our district or municipal health system. So, or if we're looking at health, our National Department of Health, all 3 of those tiers or levels would have some element of politics in them. So if we're looking at the National Department of Health, we'd have a Minister of Health, which would be an elected, I suppose, an elected official. But there are also permanently appointed people, so we would have a Director General who would actually be serving the executive function at the National Department of Health, and pretty much the same at each of those levels. So when we get to the provincial level, we'd have a Premier and a Premier of the Health Department, and also there would be a person in charge, a Director of that Health Department. So the political element is there as well, but the actual work gets done by permanently appointed people. And then we have our district or municipal health, which is our local government, and that would be the level where we would operate mainly. So for environmental health, for the most part, would probably land up at a local authority, and that is where the service is actually rendered. So unlike a lot of other health professions in South Africa that are operating at national, provincial levels, we're probably the only one that operates mainly at the local level. Public health, if we think of public health in the South African context, it's often thought of more as the health care that's provided by the state or the government than when you're looking at the real definition of public health as being a preventive service, where prevention, promotion is taking place. Here it's often thought of public health is what's provided to the public. So we've also got, when we think of health care in South Africa, we've got state-funded health care, which makes up about 80% of the health care, and then the rest would be private health care providers. State-funded health care offers to most people with the least resources. So it's really quite an unequal system. And it's also offered at 3 different tiers. So these tiers mustn't be confused with the different levels of prevention. But we've got primary healthcare clinics, which are situated in the municipal or district areas. And if you go to a primary healthcare clinic, you would get basic health services, and they would need to refer you to either a district or a regional hospital. And then the highest level would be a provincial hospital or a hospital where services are specialized. So, yeah, I think public health, yeah, people often have a wrong, it's not strictly thought of in terms of the definition that we would usually look at, or that's usually provided. So already I've said environmental health mainly functions at the local government level, and when we do the training, that's where we're mainly pitching the training. So I think by giving just an overview of what we're doing in environmental health, it also gives you an overview of the whole environmental health status in the country as well. We do training that's aimed at providing general practitioners. The training is regulated by the Health Professionals Council of South Africa. So they would say what we need to include in the training. They would be looking at the quality and so on. As well as at the end, when everybody is graduated, they need to register as practitioners with the Health Professional Council. And I think I've got bullet points that may seem random. I hope I'll be able to draw them together in a minute or so. So training is in environmental health, mainly at the undergraduate level. And at this level, there's 6 institutions throughout the country that offer training in environmental health of the 26 institutions that we have. And then, yeah, just some information previously. I think there are a few of us here that trained quite some time ago. And when we did our training, the course was actually called a Diploma in Public Health. So all those years ago, we actually thought public health equals environmental health. And that kind of, so for us, it's a very important aspect that the two are very, very closely linked. Although we know public health is multidisciplinary, made up of numerous different disciplines, which we find in our faculty. But they only do a component of preventive promotion activities. Maybe, possibly the exception is the social development profession that also works at community level. We would be the profession that is really at a local level, at the interface of the community, and definitely a level of primary prevention. We're not really going to be looking at secondary level or tertiary level of prevention. So yes, that was in the late 80s, and then from about 2015, the course changed from a 3-year diploma to a 4-year course, which actually includes what others might say is the honors level as well. And it changed its name from the Diploma in Public Health. Graduates of that diploma were known as health inspectors, which is something really, I suppose, well known. We changed to be environmental health officers, and then it changed again, and now we're environmental health practitioners. And now sometimes when we say I'm an environmental health practitioner, people are very confused by what that is. And so maybe we need to go back and rethink it, because when we say no, if they say what is environmental health, then we say, well, we're health inspectors. Everyone goes, oh, then they tend to see, you know, that's what it's about. Okay, I put this up just for interest sake. So this is our Health Professional Council that's regulated the training, and this is the scope of practice. And for our students studying, we need to, for them to be able to graduate and for them to be able to work as an environmental health practitioner, they need to have covered all of these topics. So it's quite a lot. You can see that they would be general practitioners, unlike where you have in your public health course, you might be specializing, I heard one say in addiction. So there's different fields that you would be specializing in, where we have to look at all of these matters. So we have to cover water monitoring, food control, and I will go into a little bit more detail on some of them. Waste, health surveillance of premises, surveillance and prevention of communicable diseases, vector control monitoring, environmental pollution control. Oh, that's not worded nicely. They've changed it now from disposal of the dead, because that sounded really macabre, to management of human remains. We're looking at chemical safety, noise control, radiation, port health, malaria control, control and monitoring of hazardous substances. So it's a tall order to be doing all of these things within a 4-year course. So for us, public health is really something you would specialize in, postgraduate level, and that would be the same for many of the professions in the health faculty. So any of those professions could have a specialization. In actual fact, I think public health training in South Africa as a whole is offered mainly at postgraduate level. I don't see courses at undergraduate level offering public health. When they do, it's termed a bachelor in community health, and that person would become a community health worker. So it's mainly a postgraduate study at this stage. So then just to have a look, so it seems like we were emailing each other, Bob, because I've also got pillars in here and different levels, and so maybe it does enable some comparison of sorts. So I've just put the pillars, so I've taken the scope of the profession and tried to just sort of put them together, and this would be basically what we're offering in the course to our students. We've got a pillar of, well, the fundamentals would be your subjects that we think are the underlying subjects, like chemistry, biology, microbiology, anatomy. And then we've got these different pillars. The one is community health, and I'll go through each of them separately, just not in a lot of detail, but just to give us an idea. Some of them are self-explanatory, like food and meat safety, pollution control, occupational health and safety, and the built environment. And then sort of as the roof of our little house here, we've got the professional skills, where we're doing the administration, management, so sort of subjects that would be needed in all of those different fields. So if we just have a look at community health, we've got a module in community development that our students would need to do, where they would come into contact under normal conditions. And I'm looking at this group of graduates, and we'll speak a little bit about the impact of COVID and that it's had on studying over the last couple of years, but normally would have opportunity to go into the community, to look at problems there, maybe to do some interviewing or meeting some community members. In any case, we've got a community development module, and we like for our students to be in touch with the reality of the situation that we're faced with. Also included in that pillar, we would have epidemiology, or the study of communicable diseases, and yeah, you can just see some training would also be related to vector control. I think maybe, Dirk, you would remember when this training was done on plague surveillance, and the municipality is quite involved in monitoring and doing surveillance for plague, because we are an endemic area. Then we've got our food and meat safety. That's Willem's subjects, where we would look at food quality, not so much, more food safety, all of what you need to have in place, certificates of acceptability that premises need to be able to operate. And also included in that is meat safety and meat inspection, as well as hygiene control at abattoirs and dairy producing agencies and so on. Then we've got a pillar of pollution control, and I think we'd fit a lot in here. So we would have water quality management, air quality management, waste management, environmental management. All of these are different subjects or modules that the students have to take. I'm sure I'm missing one or two here. Only we've just got some of our students also doing their practicals where they're monitoring diesel emissions. And then we've got a leg of occupational health and safety. That's Dr. Sean Ramroop's area of expertise. So this is to enable students to not just work in the health field, but to also work for a Department of Labor, as an example, or in the private industry, looking at health and safety in the workplace. And then we've got a leg that we would call the built environment. I sometimes think we can't fit everything neatly into that, but we've got a module on sustainable development. We've got planning for the built environment, and then possibly environmental management would also fit in here. And I suppose part of the professional skills that I could have added in a slide here would be the studies in law, that they also do 2 modules related to law, so that because they're going to be law enforcement officers when they leave, that's also necessary. So it really is a lot of different modules to pack into a 4-year degree. And because we're regulated by the Health Professional Council, and they've approved the training to say, you know, you're going to meet all our needs if you do this training, all of the modules are compulsory. So there's no electives in this. All of these students here sitting here, and maybe that's why it was actually quite, you know, everyone was saying I'm in environmental health, but being in environmental health here means I've tackled all of these subjects, and I have to get through all of them. And then I just wanted just a word or two on the impact of COVID and the impact that it's had on the program. So since March 2020, when we had our first lockdown, when we had our first cases of COVID happening, it was just before our normal recess, and students were actually asked to go home. And we went into a total lockdown at that stage. And that lockdown lasted, initially it was for 6 weeks, and then it was extended for a 2-month period. And in that period, academic activities actually were on hold while we tried to prepare to get all our students on board to go online or to have some form of contact. Before COVID, we were largely face-to-face contact university, and particularly in our course. And I think I'm looking at the faces here, but I think even a laptop could have been considered a luxury. So it was a lot of organizing and facilitating to get students just in contact, just on board, because many of the students were in rural areas. So being out in a rural area means sometimes there's no connection to a Wi-Fi. So there's making it really difficult to just go straight from what we'd known to online teaching and learning. But we managed, because we actually had to do it for 2.5 years, where we didn't have classes happening on campus, and we've managed to navigate our way through, luckily, Teams and all of those apps and so on that became so popular because it became a necessity. And learning management systems like Moodle we've used extensively. And if I look at this group of students that are going to be graduating at the end of the year, then it's the group that was impacted the most, because it's been 2020, 21, 22, and now only towards the end of last year we were back on campus in class doing some of the work integrated learning that we've actually missed over a number of years, because we couldn't place students for work integrated learning as we usually do. So yes, hopefully they're adjusting now to being back on campus. And at least it means for the last year, it's back for us to normal, but with the added advantage, we've now got the use of all these digital aids that we never had. It sort of fast-forwarded us into a more digital way of doing education. So hopefully that's going to have an advantage for them in practice going forward. Yeah, I think just some of the challenges, I suppose these are challenges that, not unique to environmental health, but I'd put some of them up, some of them identified already pre-COVID in 2019 by SALGO, which is an organization of local government, and they get together sort of once a year, all the environmental health departments get together, and some of these were already identified. I think just a word on the burden of disease in South Africa. So if you look at the burden of disease, then we're looking at a sort of they call it a cocktail of 4 different epidemics. So HIV and TB, maternal and child health, or lack of health, I would say maybe the high mortality rates involved there. Non-communicable diseases are also important. And then looking at injury and trauma. So if you look at that, we've got 2 worlds in one. So when we're doing our training, that's a challenge we have for training as well, is that we're training for 2 different worlds. It's a country with the highest inequalities in the world, and that translates very clearly in health systems and also the way we need to provide environmental health services. So, I mean, if you're looking at the high level of communicable diseases, but we also have a high level of now sort of catching up a high level of non-communicable diseases, and an extremely high level. I think our homicide rate is 5 times the global average. Our HIV rate, I think, is 17 times the global average. So these are things that are really challenging. Amongst the challenge, I'm sure, that are not unique to us in South Africa, that you would possibly recognize, things like climate change, food safety, depletion of natural resources, and that particularly has hit us hard here. In Quebec, I'm going to get into trouble because can you hear I'm not pronouncing it properly either. So particularly with the water, and we've had a drought for a long time with water restrictions. So if you see us smiling in the rain, you'll know it's because we really do need it. We've got other things that may be unique to South Africa that probably you've already experienced, load shedding, and how that can impact health as well. Just thinking about simple things like load shedding, for people that have got supermarkets, they now have to have alternative, more expensive means of keeping their food cold, and that pushes up the price of food, but it also pushes up the risk in terms of food safety. But there's so many impacts that load shedding has on health as well. So I think that could almost be tied in with the political impact. And that could be tied in with our poverty and our all of a sudden big drop in the rand value against the dollar. Also, we've got lack of ongoing health promotion, fragmentation of services, and then this huge scope of practice with no electives or no areas of specialization for us is a challenge in training. And then generally, I would almost say we have lack of capacity in terms of numbers of qualified EHPs, where it should be 1 to 10,000 of the population. I think maybe Dirk and Tembi could help me more. It's probably 1 to 35,000 instead of 1 to 10,000. Okay, and I think that's sort of where I can end off and just say it's our vision that the graduates from this program will rise to meet those challenges. They'll have an ability to tackle the challenges, maybe in a new and innovative way. And collaboration is important in doing that. So we welcome the collaboration today as well. Thanks. I don't know if there's any questions or if I've got time.
Listen, thank you. Give her a good hand. Thank you, Cheryl, for that comprehensive explanation. I think I'm going to leave the questions after the three people are finished today because due to our time here. I can maybe just say, before we get ready for our next presenter, unfortunately, primary health, as you indicated, Prof, is normally something that is not seen and recognized by top levels until the fan hits them. Then it's been called upon, and therefore it is so important. I'll always, request the students, that job that you do, based on safety and so on, is critical. It is not always recognized and acknowledged by government officials and so on, due to the fact when things are going right, we don't see it. And I think Cheryl was highlighting on some of these issues as well, and you as well, Prof, in your presentation. And that is one of the negative effects of primary health care, I think globally, that it's only recognized when we've got outbreaks, then the guys have to, take all the risk and so on. Well, Eva, I want to introduce you to our next presenter, Dr. Sean Ramroop, who is with us for the last 4 years. I think as with our 4th years, he did exactly the same. Basically, on his arrival here, COVID broke out, and, we had to work, as our HOD indicated, to learn very quickly, work online with tremendous amount of challenges, as indicated, to get to our students very fast. But I think Dr. Ramroop fit in perfectly, and as a registered environmental health practitioner with the Health Professional Council of South Africa, and is also a registered occupational hygienist with the South African Institute of Occupational Hygienists. In excess of 25 years of public and private sector experience in occupational and environmental health and safety, he has been lecturing part-time also for over 10 years in also the Joburg vicinity. I always feel sorry for them coming from there, but my sympathy is not helping. They're making a lot of money there, as I indicated, as the Golden City. And before he joined us and make a very good choice to come and join us here at the Nelson Mandela University for the last 4 years, and I think he contributed tremendously already in his short time here, and he's also fitting in and so on. He's currently a senior lecturer in environmental health, and he's the postgraduate coordinator in the environmental health department for masters and doctors students, along with Prof. Melariri there at the back, which he took over from. His research interest currently is lower back pain in truck drivers and arm vibration. And Dr. Ramroop will now do a presentation for us on presenting on environmental health postgraduate studies as the postgraduate coordinator. So he'll give you a little bit background on how our staff is working here postgraduate. Thanks, Dr. Ramroop.
Thanks, Willem, and greetings to all of you. The province issue. Let's leave that aside. But just to also tell our guests, before they leave, they must enjoy some of the local cuisine here. I'm also not from the province, as Willem mentioned, and you have to. I think that's very critical. The other issue is the issue about wellness. I think I have to say this. Getting us to stand at one point here, it's a big issue in my profession. Remember, it's an ergonomics issue, just standing in one place. it's the man-machine interface. You need to change the man. You need to change the machine rather than the man. So for the next time, we think we need to sort that one out. Okay. The other issue is Doc Robbins. I think you need to just give me a brief explanation of the Western Michigan University and the difference with the University of Michigan. Why I ask that is I've done a lot of work with the University of Michigan, Prof. Thomas Robbins and Stuart Robbins. Okay, so if probably after lunch or at lunch we can see what's the difference. I'm quite interested to know, or if it's the same university, I'm not sure. Okay, in terms of my presentation, what I want to do is just highlight some of our postgraduate programs that we have at the university, especially environmental health. Basically, what I'm going to do is explain the programs. I will just touch on the institutional research themes. I'm not sure whether you all have been introduced to it in your other discussions. Also the research teams of the environmental health department. This is where we kind of going to. And then what is the status of our postgraduate studies in environmental health presently? It's a relatively a new area of focus. I think it's been an area of focus when Prof. Paula joined the department, and she's been pushing the postgraduate studies. And I think we all know it's the currency of the university research. So it's an area that we're actually giving a lot of effort into. Next slide, Willem. We offer 2 postgraduate degrees in environmental health, okay? We offer the Masters in Science in Environmental Health and also the Doctor of the PhD in Environmental Health. And both of these degrees are research-based, okay? They're not a course-based program. And just to also highlight, there's a lot of programs in the country that we have degrees in public health. And the degrees in public health basically are a coursework based together with a research project. Okay, so there are a lot of courses that are being done in public health. However, also in environmental health, and this is the interesting part of our degree, we actually encompass both public health into the degree, because our focus is both the internal environment and the external environment. So we do a lot of public health in the environmental health degree. And if you look at the research outputs in the country in environmental health, you would see it's all based in public health issues. Okay. Next slide, Willem. The institutional research themes, I think in 2017, Prof. Paula, this is what the university sat down, consulted, and they came up with these 6 themes. And it's the themes that focus on ocean and coastal sciences, social justice and democracy, environmental stewardship and sustainability. And that's the area where we at environmental health mostly focus in. The innovation and digital economy, origins, culture, heritage and memory, and humanizing pedagogies. So these are the 6 themes that the university has strategized on, and it's the focus of Nelson Mandela University. We at environmental health kind of focus around these areas in terms of EPI, the tropical diseases, food hygiene, environmental pollution, and occupational health and safety. So this is our research focus areas that we kind of thinking about going towards. And there's a lot of work that's already being done in the tropical diseases area and also in the food hygiene area. With me joining in, I have started in the field of occupational health and safety, pushing out a few projects on that. The next slide for him. In terms of the completion rate, as I mentioned, we started postgraduate studies quite late. And as you can see, the degrees that have been completed to date, it's mostly the Masters in Technology Environmental Health. It's a degree that was in place before we came up with the Bachelor's of Science degree, okay? And in 2020, there was 2 graduates, and in the years 21, 22, there was 4 that has completed, and the 2023, it's the last person that has completed, and that's the last of that degree. It's completed, and no one else can actually enroll for that degree. So from here onwards, we will be churning out the Masters in Environmental Health and PhDs in Environmental Health. Okay, next slide. Our current registration of postgraduate students in environmental health, if you look at the MSC's environmental health, in 2019 we've got 1 registration, 2022 2, 21, 22 is 1 each, and I think this year we've really increased the output where we've got 4 registered students. So as we stand, we've got quite a number of Masters in Environmental Sciences students. And in terms of PhD, for 2023, we've actually got 3 current registered students. Next slide, Wilhelm. Our prospective students, this is where we're looking at for 2023. We've already accepted 1 Master's in Science and 1 PhD. They have to get themselves registered, and they will be added to the previous slide. Our pending, we're sitting with 2 PhDs, and those applications are pending, and we also have 1 new that has made an application. So that is basically our status of the postgraduate studies in environmental health, and I think it's quite an exciting area, and it's an area that we're actually looking forward to. Thank you very much.
Thank you so much, Dr. Amrup. I think before we go over to the Michigan University presentation, let's quickly have a look while Dr. Amrup, you put us back in time, so to say. Maybe if there's any questions at this stage, you know, because it's related to the 2 presentations that was done now, if there's any questions. While the Michigan guys are just setting up their presentation there. Yeah, I think maybe just a little bit background on that as well. Previously, when the scenario on teaching was completely different when we were known as a diploma. It was a 3-year course where your 4th year was a postgraduate course. And, you know, it was a lot of in-service training actually occurred there in those days. And now when we are full university at this stage where it became a full degree course, the 4 years, your first step after that is obviously your master's, and it started to progress. I'm going to hand over to the Michigan presenter again, and they will give us the COVID response, which I think hit all of us globally. Thank you so much, Prof.
Thank you. Goedemiddag. I'm trying. So we, as a group, thought it would be very interesting to share with your group the U.S. response to COVID-19. We all know what COVID did. We all know about COVID, so we're not going to go into what COVID is, but really taking a look at it in terms of how our university responded to it, and I'm going to share some about that, and then our students are going to sort of walk through a timeline, year 1, year 2, year 3, what happened in the U.S. And so thinking about it from your perspective, especially students, you know what happened here, and maybe you saw on the news some things that happened in the U.S., but they're going to give you a blow-by-blow account of actually how it impacted their lives and our lives in the U.S. And so from the standpoint of COVID-19, as a professor in public health, it was the most exciting time for me to teach in the middle of a public health pandemic. It was a phenomenal opportunity, even though we had all of the challenges like you had with the lockdowns and everything else. Having my students be able to be in a real live public health pandemic, practicing the skills that they're learning in the classroom, could never get anywhere else. And so it was a great opportunity. So let's step back into March 13th, 2020, which is about the time that our university also we went online right away because we had the facilities and the capability to do that. Not all of the professors were capable of actually teaching online, but the students had all of the capability to do that. And if we look at the COVID map, and we have the US and Africa and Europe and China, and everything was blowing up in Europe and in China at the time. France and Italy and China, that's where COVID was really exploding. We go back 3 years ago, there were only 5,000 deaths. And now we know there's well over 6 million, 7 million deaths worldwide from COVID. But at that time, there were about 5,000 deaths. The US was not really on the chart as near the top of the list at that point. So we were located down here. I just want to put that as a frame of reference because when I end my little piece of this, you're going to see how that flipped quite a bit. So when we came back from our recess, which we call spring break because we are opposite of you, our fall is your spring, your spring is our fall. So when we came back, our university on March 10th said, okay, lockdowns, we're going to go online, we're going to cancel classes the rest of the week. This was on a Tuesday. We're going to cancel the classes so professors can get all of their stuff switched to online. Then on Monday, we're going online every single class. And so it wasn't a 2-month delay with that standpoint. So we did that right away. And I thought, okay, great opportunity for my students to get involved in this process. And so I contacted the officials in the university who were developing the crisis response team. And I said, hey, we've got public health students who are trained in how to deal with this. They're trained in health communication strategies. They're trained in epidemiology. They're trained in a lot of skills. Can we be part of the solution? And the university said, absolutely. You've got students with expertise, bring them on. And so on March 15th, which is a Sunday, they said, we are meeting as the crisis response team. We want your students there, and we want you to be part of the solution. So what happened from that is we brought forward and said we could develop a social media campaign, health communication campaign, of being able to deliver to students some of the key messages that you're trying to get across, because our students know how to do that. And they said, great, you take care of all 25,000 students at the university in terms of messaging. We will take care of the faculty and staff and everything else. So our 10 students that we had put together a plan, and they delivered social media, delivered social media messages around flattening the curve, because not a spike in COVID, but flatten the curve, have grace and patience while we're transitioning as a university, and be healthy. Keep yourself healthy along the way. And so we ended up delivering over 6 weeks. They delivered 66 different posts with almost 12,000 views from students. And we measured engagement, we measured reach, we measured all of the different things you can measure in social media. And here's a couple examples of some of the posting, having patience, and I stay at home for the health of my family, and the different type of messaging that went out was all based on public health messages that the students developed based upon the theoretical processes that were most likely to be successful. That was our number one opportunity to get involved in this. Okay, so then I said, hey, we've got some public health experts. What else can we be part of? And they said, you guys did such a great job of that. We want you to be on our fall reopening task force. Our fall is September, October, November. And so throughout our summer, which is your winter, they said we are going to be developing all of the type of messaging that focuses on social distancing and sanitation and wearing masks, and how are we going to deliver that through all the buildings, all the campus buildings, as we go back face-to-face starting back in September. And so our students got a chance to help develop all of that process from that perspective. Then it was like, hey, what else can we do? And our students, and our postgraduate student, Magali, was part of that group, and we said we want to develop a coalition, a COVID student coalition made up of different students across campus with our public health students, being able to then take aspects and continue to educate with populations. And so the newspapers, the media all got involved in this. They connected with what we were doing, and I just want Magali to share a little bit about what that coalition created or got engaged in.
So hi, everyone. So yeah, this coalition was a student-led coalition, and its focus was on putting out efforts and messages to the campus community in order to remind them of COVID-19 safety measures in order to keep us, the students and the faculty on campus, as safe as we could be. So we did various initiatives. We created messages to remind students. A big focus was our social media initiative. So we created accounts through various platforms and posted reminders. And we updated the campus community on the COVID cases on campus so that they were aware of the status of COVID-19 on campus. We also passed out masks, posted signage on campus. We volunteered at vaccination clinics once those were available. And there was various subcommittees through the coalition. So because all of our students were in different focus areas, we were able to create subcommittees that focused on outreach and gathering more students to join our coalition. We had a subcommittee that was only specific to social media, to community resources, and yeah, so I think that was it, right? Yeah, that's it.
Yeah, thank you, Magali. So messaging about getting tested, messaging about wearing your mask, all of that. And they did a fantastic job of delivering that across campus. Even from the perspective that our state medical director, which would be your provincial medical director, gave a shout out in a tweet to the efforts that they were doing at our campus, Western Michigan University. So then, at this point, the university was kind of figuring out that our public health students were pretty valuable in the mitigation of COVID. And they contacted me and said, can your students get involved in our contact tracing on campus? So when, I know contact tracing happened here as well. When somebody was infected, then you would call, identify who else were you with in the last 3 days, et cetera. Magali was also part of that. And so we had, over that period, we had 10 of our public health students working 84 shifts, and they conducted 50% of all contact tracing faculty, staff, and students in our university. So they were a huge essential healthcare or public health service for the university from that perspective. So then we were able to get tapped into or connected with our national public health agency, CDC. They were doing a mask surveillance project where we had individuals that we had enlisted from our public health program who were then out and they were doing some surveillance of people as they're walking into buildings to determine are they wearing masks appropriately and what type of mask, to get an idea of how effective some of the efforts were that we were doing with our perspectives. And then we had two of our students, Magali again, superstar Magali, because she was in that 4-year program during COVID. She was in there. And then Alessandra, who engaged in this process. We had 17 students. They observed over 1,500 observations, surveillance of mask wearing. And Alessandra's going to share just a little bit about that.
So I've taken the long route in completing my undergrad, so that's why I was a part of this. And you could tell that was a long time ago because that picture of me was very old. But we all sat on different locations on campuses, so we were in different buildings where most of the classes were held. There wasn't high traffic number of students because a lot of our classes were still online. But we would sit at a location on campus, and then we would have this kind of like recording sheet of how many people that we came in contact with or that we saw, what type of mask they were wearing, if they were wearing one at all, and if they were wearing that mask correctly. So we would record that. It would get sent to the CDC, and they would record throughout campus how many students at this university were wearing the correct type of mask or if they weren't wearing one. And these were the numbers. So 97.75% of students that we recorded wore masks. The most common mask type was cloth mask, and then 96.6% of students wore masks correctly. So out of the 178 observations, 94.4% were wearing a mask and wearing it correctly. So that was a lot of students that were wearing a mask and were wearing it correctly.
Great, thank you. And this is just an example of 1 week of that observation. That took place for 8 weeks. So then we had an opportunity, since we started to get into the media and with the local newspaper, the local television stations, they were contacting us, they were reporting us in terms of what is Western Michigan University doing. This is fantastic. The local district health departments around us where we're located, they started saying, can you be part of our vaccine clinic? And once again, Magali was part of that. And so being able to go out and volunteer and being part of the vaccine clinic, not doing vaccinations because our nursing students were doing that, but in terms of people flow, moving people through, observing them after the vaccine, our students got involved in that. And so we had 6 of our students work at 3 different clinics. And this is a map of Michigan. It looks like a mitt. That's where we live. And we live right there in that red square. And so each of these squares is a district health department. And so we worked in 3 of these different district health departments in the vaccine clinics, and that's where they were located. And so for some of you, you're like, Michigan, where's Michigan, where's Michigan? If you go way down to the bottom right, that's where Detroit is. And if you go straight across what this would be a big lake, this is where Chicago is. So we're right in between Detroit and Chicago in the north part of the U.S. So we got involved in that, and then the coalition, the student coalition, created this campaign about this is your shot, because Western Michigan was starting to do vaccinations on campus. And so the whole campaign they developed was this is your shot at being healthy, your shot, everything. So that was a pretty cool campaign. The 7th opportunity that we got to be involved in, and now we started to move into the next year with the next group. And so in this group, we were able to work with the district health departments, more of them that were around us, and we worked in 5 of those agencies, the district health departments, and we created 12 health communication social media campaigns. Like we did, originally we did the one for Western. They came to us and said, we'd love to work with your students. Can you create a campaign on vaccine hesitancy? Can you create a campaign on how to encourage youth to get vaccinated? Can you create a campaign on dispelling the myths of the vaccine? All of these different types of things that they then implemented bits and pieces within their populations. Then in the last thing that we got involved in is a number of our students, 5 of our students, actually got hired by our local district health department as employees to work in COVID mitigation. And collectively, they were paid and worked 2,000 hours over the course of about 4 or 5 months. And Madison was one of those students.
So I worked at the COVID call center in the Department of Kalamazoo Health District. I worked there from November 2021 to April 2022 during both the Delta and the Omicron surges. So I would mostly get a lot of callers asking how to isolate, how to quarantine, because there was a lot of confusion between both of them, and a lot of hesitancy to quarantine and isolate, because a lot of people were worried about not being able to work and pay their bills. So I was also a great resource in how people can get funds to support them when they were sick. And then I'd also tell people where they can get free masks, where they could get vaccinated. I would make also appointments for people to get vaccinated as well.
Great, thank you. And so as a part of the output of all this, we published a number of papers in professional journals that represented these activities that these undergraduate students did. Not master's and doctoral students, but undergraduate students got involved in. And the whole thing, that why I shared this, just it's an example of we did not wait for the top down from the university to say, here's the plan, here's this, here's this, here's this. We put our hand out there and said, listen, we've got some skills, can you use them, because we're all trying to figure this out. The university jumped on that, and then the students were able to just get massively involved in doing all sorts of COVID mitigation and practical experience that they have that they would never have been able to get. So that's, for the faculty in here, if you have other things that occur that come along your way, have the students be the solution. And so, in the end, 3 years later, this past March, now we've had close to 7 million deaths with COVID, and the U.S. has become the largest in terms of COVID cases, COVID deaths. The U.S. has the most advanced healthcare technology in the world, the most advanced public health system in the world, but we are 4.5% of the world's population, and we have 15% of all COVID cases and 16% of all deaths. You would think it would not be that way, but it ended up that way. We had the technology, we had everything, but we just blew up. Now, what you're going to hear from some of our next group that's going to come up, they are going to talk about some of the timeline, and you'll start to see maybe some of those reasons why we didn't have a really good control on COVID, even though we could easily go by self-tests at the local pharmacy or clicks. We could just pick it up there. You can buy them. You could get them. They're readily available once COVID got into the process. So I'm going to ask Jake, Lexi, and Sarah to come up, and they're going to go blow by blow. This must be a U.S. concept. Year 1, year 2, year 3 in relation to the pandemic in the U.S.
All right. Introduce who you are. All right. So hello, everyone. My name is Jake Line. I am in my final year at Western Michigan as a public health student. And COVID hit my freshman year, or my first year at Western. And so one of the issues is the death rate in vulnerable populations in the U.S. was staggering. Essentially, if you were over 65, you had an incredibly high likelihood of dying from COVID. And older adults, people with who are immunocompromised, low white blood cell count, and had pre-existing conditions, especially upper respiratory conditions, were at a way higher risk of catching and dying from COVID. And these deaths were reported by the media, and this just began to fuel a panic and a frenzy. And so for lack of information, there was not really a cohesive response from the 3 tiers of our government. And so there kind of was this gap in information. And so that left the room for misinformation or information that was just wrong because people didn't have the tools to find the right answers to keep themselves safe. And lack of PPE. During the pandemic, hospitals were incredibly full. Emergency rooms were booked to their maximum capacity, and there was an extreme shortage of ventilators. It was so bad that there was an executive order signed to have Ford and General Motors convert their plants to make ventilators for the hospitals. And similarly, we went all online for our education, and that was K through 12. Everybody, all students in the U.S. were online, and it was challenging, to say the least, because having to switch, we had 1 week to figure it out, and it was all trial and error trying to get education done. And essential businesses had to adapt to the new policies, so only certain businesses were allowed to stay open. And those were like grocery stores, hardware stores, and ironically enough, liquor stores were able to stay open. And that caused churches to close, and so that forced people to gather online. And all of this fueled the political divide because a lot of people felt that small businesses should have their chance to stay open so that way they can pay their people. And that was essentially the beginning of the political nightmare.
Yeah, so, continuing off of that, my name is Alexis Rozak. I'm also in my final year of public health at Western Michigan. And I, at the time, was working in an inpatient psych unit. And Jake had previously mentioned that most of the hospitals were full due to COVID and things like that. But what people also didn't realize was that they were full because people couldn't see their family members. They couldn't see their friends and things like that. So the access to that was kind of interesting. I kind of wrote down a statistic so you guys have an idea of how bad it actually was. According to the National Alliance on Mental Illness, more than half of Americans reported that COVID-19 had a negative impact on their mental health. And in February of 2021, 39.9% of adults in Michigan reported symptoms of anxiety or depression, and 27% of those were unable to get the needed counseling or therapy. So that was kind of interesting. From my point of view, I worked in the inpatient psych unit, but we also had an ER psych unit for patients that were just coming in, and between both of them, we could not find beds for people to stay and get the help that they need, so that was kind of interesting. And then, like I said, most people didn't have access to go see their family. This included people not being able to see their parents or family members that were in like nursing homes and senior centers, so that really put a damper on things for a lot of people. And then a lot of airports also shut down, so that kind of like I said, also put a damper on things. People really could not travel to see their family members and friends. And then with that also came an increase in substance use. I put another statistic on here so you guys can kind of see that. And that's according to the Kaiser Family Foundation, the pandemic has coincided with an increase in substance use and increased death rates due to substances. In 2021, there were over 106,600 deaths due to drug overdose in the United States, which was the highest on record. So that kind of also put in perspective and goes along with mental health and things like that as well. And then leading, kind of like how Jake had mentioned, the political divide, it actually grew to be really bad, kind of worse than what we all expected. And the leader of our province was actually in danger due to the COVID restrictions that they had put in place, which was kind of crazy. People were making threats and stuff like that. Basically, like wanting to kidnap her was a really big one. So that was kind of interesting. Yeah. And then came the emergence of the COVID vaccine. That started, I believe, in December mainly of 2020, where the first people who received it were the immunocompromised, so people who had any kind of, whether it was like a virus, no, sorry, I'm trying to think. Yeah, like any kind of disease, anything like that, where they were immunocompromised or yeah, and then next was 65 and older, so the senior population, the older population, and then it went to frontliners, who were the people who were like nurses, doctors, people who were working in the field. That also included grocery stores, people working in liquor stores, basically the main people who needed, or who were there to run what people needed. And then the last one was anyone above the age of 12. So I'm going to pass it on to Sarah, and she's going to talk more.
Okay, so like she said, my name is Sarah, and I'm a year behind the two of them. So when COVID first started, I was in high school. It was my last year in high school, which is 12th grade. So when I went into college, it was already COVID, so I had a bit of a different experience than the two of them. And so, like Lexi said, this is when things started to get a little bit more normalized, so all the celebrations that were pushed off are now happening. And anyone that wants to get the vaccination can get the vaccination. And now booster shots are coming out, and they go through the same process that the vaccination went through. So anyone who needed it first got it, and then it was open for the rest of the population to get. And one thing that we really saw that was a struggle here was the workforce, because you'd think that right when COVID ended, everyone would want to get back to work and get back to the normal life, but that is not what we saw happen in the U.S. Because when everything shut down and people couldn't work, they got checks from the government that helped them live, so people got very used to living at home and being with their family all day. So when work opened back up, no one wanted to work. So we saw many businesses shut down, and a lot of them struggled to stay open, which was a big struggle for kind of what Jake said. So a lot of family-owned business couldn't reopen after COVID, and in my town, a lot of restaurants could only be open 3 to 5 days a week because they didn't have the staff to work them. So that was a huge problem that we saw right after the U.S., or not the U.S., right after COVID started normalizing. And disbelief and misinformation 3 years later was still happening, unfortunately, in the U.S. So many people don't believe COVID was real in the U.S. So there's some people who think that COVID was just made up and isn't a disease. And this is one of the many reasons that people didn't get vaccinated in the U.S., because we have many people that chose not to get vaccinated. And another reason is there was a lot of conspiracy theories out, and there was tons of them, but just one of them that we all thought was a little crazy is that the vaccination would change your DNA. So many people thought that you would just completely change as a person if you got the vaccination. So many people didn't. And kind of going back to the struggling workforce with the misinformation is people who didn't get the vaccination in some like workplaces, many medical places would get fired. So if you didn't get the vaccination, you could no longer continue to work there. So this also fueled the workforce struggle because many hospitals needed more nurses, and if the nurses refused to get the vaccination, they'd get fired. So this also was a problem with not having enough employees. And then we had lack of consistent messaging. So like Jake said, on the first year, we didn't know anything about quarantine, and 3 years later, we still didn't know anything about quarantine. So people were confused if they had the vaccination. It was different than if you didn't have the vaccination. Some said 5 days, some said 7 days. So a lot of people were still very confused about when you should stay home, when you should go back to work. So that was still confusion 3 years later. And now we know that COVID is something that is like the flu, so it's going to be something that never goes away, unfortunately, and that there's going to be boosters that are going to continue to come out and vaccinations that are going to continue to keep coming out.
Thank you for these 3 students sharing that. And if you follow any of the U.S. news with our politics, politics is an issue we have too. We have 2 very split, powerful parties. 50% here, 50% here. Donald Trump here, Joe Biden here. And it tends to be the Donald Trump people that are the ones, the conspiracy, COVID's not real, we're not going to mask, we're not going to get vaccinated. And so there is this huge divide right now in the U.S. that we haven't seen for years, and it's unfortunate. All of us want those guys who are like 80,000 years old not to run for president. Get somebody who's like 50 maybe or something like that. So that's where we are in the situation. And so COVID was a mess for us, a huge mess, even though you might think, well, wait a minute, you've got all this stuff, you've got all the technology. Yeah, but it was still a problem. And so we want to open this up if you have any questions, especially the students, that our students could answer. I mean, you don't have to, because I know you're going to integrate and talk more about this. Yes? Can you pass that back, please?
It's not really a question, but a comment on the point you mentioned on disbelief and misinformation. We get that a lot, and in most of our communities, you get people saying those people that died during COVID are actually weak, because there are some of us who were in contact, I am one of them, with people who had COVID but didn't show any signs and were not affected by the COVID virus. So I think there's still a long way to get there, just to inform people about these kind of things, because if COVID hits again, I think we're going to have a big problem. Thank you.
100% agree with that. And this was the misinformation, disinformation, all the tweets and all the things that just were not real. And so, yeah, you experienced the same things. And another thing that we have, and I'm assuming you probably have similar, we have this long hauler syndrome, which we have 30%, about 1 out of 3 people who've had COVID in the US still have this long hauling loss of taste or flu-like, or they just are not right where they were beforehand. Yes, did you have a question?
My name is Aziwe. Just to add on what Lisa said, it's also a matter of education because people know what they should do. They have the systems in place. And okay, if this hits, you know what to do. But then many people are not equipped on how they can actually implement the systems that are already in place. Like you'd find communities that are disadvantaged. There are authorities that have the resources to help them, but then the people don't know how to actually go to them and how to actually respond to those systems in place. So I feel like it's still a long way to go. People need to be educated, and that's also one of the things that us as environmental health practitioners are also part of, which is raising awareness and educating the public on the systems that we have and how to actually go about it.
Yeah, that's a really important point. And I think for us in the US, a big part of what we're trying to do is rebuild the trust that was kind of lost in COVID because a lot of misinformation did come out and was coming out from the government. So they're trying to rebuild the trust in the population. Rebuild the trust in the population where people will believe what's coming out because that is the truth.
Hi everyone, I'm Asake. Besides the whole thing of miscommunication, most people, especially here in South Africa, were ignorant. Because as you were saying about the miscommunication, I have this video in mind where this man is like, no, we won't get COVID because we don't fly, meaning they don't travel. So there's just ignorance in the people in South Africa, and I'm sure in the US. So that's all. Thank you.
Good morning, everyone. My name is Faith Kundo. Firstly, I would just like to applaud you guys in your involvement, especially trying to curb COVID-19. It's courage, guys, and yeah. Secondly, I wanted to comment on some of the challenges that you mentioned, and it was the lack of PPE. We relate very well as a country due to the fact that we have a very corrupt government. So we've had cases whereby there'll be distribution of funds from the Department of Health to actually work on ensuring that each and every citizen has the proper PPE needed, especially face masks and all of that. But we ended up not seeing where the money goes. Instead, we ended up seeing more and more, especially the marginalized people suffering due to that. So yeah, it's some of, we practically had the similar challenge, especially with regards to the lack of PPE. So yeah, thank you guys.
Okay, good morning. Yes, I wanted to ask a question because when I observed the COVID time in South Africa, relating to my country, I found out that my country was not highly hit by COVID. But in South Africa, there was a high risk of COVID in America. So also, did people take consideration of the weather condition? When the time was very cold, you will see a lot of increase in cases. And when the sun was hot, you see there was a big decrease in the cases of COVID. Because we are from the hotter region, we never have a severe COVID hit in my country because due to the hot climate condition. But I didn't see something talking about the climate condition relating to COVID.
And I've seen your spikes and trends of when the big spikes were, and it relates around the colder conditions. That's the same with us. We spend 4 months of the year in snow. And so back where we're from, spikes of COVID, because you're inside, you don't have ventilation, you don't have all of that happening. So we had similar spikes that you had. Here.
Winter seasons, we are exposed more to the cold, so we more fluent to get the flu. So already your system is immunity comprise, you know. So I think that would also be a factor that would add to the weather playing a part.
Greetings, everyone. My name is Lina Temba. I would like to applaud the way the US or the Western Michigan University has responded to COVID. I would like to say our country could like learn a lesson in that, like putting like more fresh and active minds on ground, like to respond to COVID-19 rather than those old people, like those ones, those that are ignorant, let me say. Because someone has mentioned something about being ignorant and stuff. So I just wish our country can learn a lesson like hiring those fresh minds, those active minds, like be there on the ground, especially students that are doing environmental health or public health. Thank you so much.
And we have nothing against the older population. It's just that it's just that we're more active. And come on, guys, we were the most that we didn't get the more we weren't more infected than you guys. So use us, utilize us.
Okay. All right. Hey, guys, I'm calling you in order. From the local authority perspective, we did respond to COVID. You'll see my presentation. It might not have been widespread, but yes, we did do something. But what I wanted to say is to really applaud the involvement of the students from the university perspective. And I think if we followed the same approach, because we did respond, when I talk about what we did at community level when we responded to COVID, you'll see. But I think with the involvement of the students, we could have covered far much greater and far much wider. So I think, and I was saying to my colleague Cherise in the bathroom, I think if we are to move forward and learn, because now these things are going to be here, you know, the epidemics, endemics, and so on and so forth. And I think this is just one of the areas where we really need to strengthen how we then make use of the students that are within the profession, working with the local authority to make sure that, you know, we reach far wider. Thank you so much.
100% agree. And look at all these brilliant minds here. Yeah. Brilliant minds who are eager to apply, right? Yes. And they don't need old guys like this, right? You need them doing it, right? So that's great. Yeah.
Yeah, can I say something as well? Yes, I want to applaud the involvement of students, but I want to also bring something else. We're struggling with regards to public health issues. We're struggling with new behavior change frameworks or models. And as much as now we're talking about COVID, on this campus, we're struggling with gender-based violence, which is becoming a public health concern. And it would be interesting for us to learn from you guys in terms of what are those behavior change models that we can use, because the current models that we are using obviously are not working.
What are the current models you're using?
Well, we do have, you know, Prochaska's model of behavior change. We do use that one. We also use the health belief models. But something obviously is not working out, and would like to know which models one can be able to
I'm going to
put
turn
in
this
place.
over to my students because we have taught this. And let's see what they have to say. Theory of planned behavior. Exactly. Good answer, right? Health belief model is a great model. It is a great model if you can really get them to understand the severity and the risk. That's critical. Then the threat is there with that. What we've been playing around with is putting models on top of each other. So then you look at perceived severity and you say, okay, let's put Prochaska's stage of change within that concept. So you start to layer the models on top of each other so it's not just one model. But you take constructs from different models and create a new model. That's the trick. And I think things like COVID we've never had a COVID. That allows us to create new models of how we address things. I think I'm getting shoved off the
Thank
stage
you,
here.
Prof.
Thank you.
Thank you, guys. I think I'm going to call it now. We're going to have tea now. Okay, I'll give Dr. Amroop the last opportunity there. Can somebody just give him that mic there? That's that one there.
Thanks, Willem.
It's not on.
Thanks, Willem. I've got a question, and it has to do with the timelines. What I'm interested to know is how you all got involved and when did you all get involved. The reason that I ask this is for the simple reason that in our country, when it first started, everything was locked down. Even the students, I mean, the university was locked down, they couldn't be here, they all went home, they did not want to come back. So as much as they say they wanted to be involved, they did not want to come back. So I just want to know the timeline. How did it work with y'all? Because like, yeah, it was just a no-go, and it was just the municipalities and the health professions that really, you know, got involved, and everyone else had to kind of, you stay at home. So if you could just give us a brief idea of how y'all worked in terms of that. Thanks.
So the timeline with our students? Oh, in the country. So we knew that, let me get on the box over here. Okay. And I don't think you're in the picture because you're tall, and I think it's getting your, you know. So we started hearing about this in December, January, when everybody else did, in what was going on in Wuhan, and that all of that was happening. And so we started to, we thought, yeah, we're over, you know, across the ocean. We've seen the Asian flu. We've seen those things come and go, and they've maybe gone, worked their way into the Middle East or whatever, then they disappear. So we didn't really think about it. And then by March, by the end of February, it was all of a sudden that, oh my gosh, we have, it was in Seattle, Washington, were our first cases, in New York City. And they were coming from China and from Europe. And so all of a sudden, immediately the epidemiologists, the public health system started tracking that, and they saw this was a massive spread, like a huge spread. And so then within a week, the states, all of the 50 states had plans in place to shut down, lock down, and they already made decisions. Essential services are going to stay open, which is all of the healthcare. It's the supermarkets. It's the home store, fashion, or hardware stores. It's the liquor stores. And the reason why it's the liquor stores is because the government gets tax from it. So I think that's why. But that immediately went in place. And then all of the universities immediately went online. All of the primary and secondary schools immediately went online because the capability of doing that was there. And we were all then pushing for, when's the vaccine coming? When's the vaccine coming? And where the Pfizer vaccine, where that is made, is where we live. It's in our hometown, which was pretty exciting for us from that standpoint. It's where Western Michigan University is. And so then we were waiting for that, and then the vaccine came in December, and then we started to vaccinate individuals on the priority scale that Jake had mentioned. Is that what you're asking, that timeline approach? Oh, the students? They got involved 2 days after the university decided to go online. They got involved right at the start. Yeah, we came back from our recess. I had students for 2 days in classes. The university said we're going online. We contacted right away, got involved right away, and then we were part of the whole process from that point. And we didn't lock down the university. We all went online, but we worked. The coalition worked online. Yes, Katie. Yeah, we went online, but we didn't lock down the university where it shut down for 2 months. Everybody. But we did all of this work then online with the students. So we weren't doing in person, but we were meeting on Zoom. Nobody had ever heard of Zoom in our country before COVID. Now everybody knows Zoom is a word. So we were meeting online. Is that what you were asking? Yeah. And just to answer, we have 15 public universities in our state. University of Michigan is the largest, Michigan State is one. We have regional ones, Western Michigan, Central Michigan, Eastern Michigan, and then we have some private colleges. But that's how that system works. Every state has their own systems. Okay. Thank you. And now I think we're going to have tea. Where's that guy from Namibia? Oh, here he is.
Thank you, guys. I will allow, I've been overruled by these good questions and so on, but we're just waiting for our tea to be ready. Yes, I think interesting. I think many of the challenges was very similar that we had. Listening to you guys, they really locked us down here. Not only alcohol, also cigarettes for those smokers, and it obviously led to new trades, new interpret guys starting to doing their own, developing their own alcohols, and I don't know, they made all sorts of schemes to get hold of cigarettes, the smokers and so on, and they got arrested for that as well and locked up for that, and some people was locked up running around the beaches and so on. They went really overboard there, so we had a lot of challenges here. But I think those that you mentioned here in the institution as well, at one stage our students, health students, also got involved by monitoring temperatures at the gates, are you sure? I think I've seen many of our students coming in when they started to slowly allow some of the staff to come back to campus and so on, under very strict rules and so on. We unfortunately lost quite a number of our personnel as well. Our own dean passed away by way of COVID. From our local authority, guys that worked very closely with us, we lost a couple of them as well, and within our institution, quite a number of personnel as well. So sadly, we have to, deal with those issues as well. In our thing. So I don't know, is there any other questions, guys? You saw me, I strictly stopped it now, but our tea is not ready. So let's proceed with one or two questions there. Yes, one here. I'm just looking for the other mic.
I'm actually curious. It's for the students, the question that I have. I just wanted to know, how did you guys manage to cope with being involved in assisting to curb COVID-19 by the things that you were actually doing, then the schoolwork, and then COVID itself being something foreign for everyone? How did you go about that? How did you balance between the work you guys were doing, being part of the task teams that worked on assisting, and lastly, adapting to COVID as a pandemic?
I will say I was very stressed. Personally, just because I feel like I was impacted by COVID a lot, my mental health wasn't where it should have been. But I had a really good support system that allowed me to cope with everything. Sorry, I'm getting a little nervous. But being online also helped me manage a lot more things, because I didn't have to account for travel time and other responsibilities. I was able to jump into all these activities, and although I was stressed, I was thankful for the opportunities that COVID did bring to us, because I wouldn't have gotten that experience as a student jumping into the professional world, because like Dr. B said, this was right on the time where I was about to graduate, or like my last year, where we got all these opportunities. So I'm very grateful for that. It was hard, I'm not gonna say it wasn't, but I think every person handled it their own way. But personally, I had a really good support system, and I already was one of those people that managed my time pretty well in all my activities, but I struggled. But yeah, hopefully that answers something.
Yeah, thank you. And I think as well, the vaccinations, if you look at social media, what some of you mentioned even today, you've got the most cleverest people that's living on social media. They've got comments on everything, you know, and they, without research, they can tell you exactly what is the results of it, and you're going to drop dead suddenly and these type of things. I don't know if you guys also had all these challenges over there. That was massive even until today. You know, you find them over there, and I think a lot of our people are sometimes getting influenced by social media on these individuals that makes all these comments and so on. But it was a real challenge for us here in South Africa at the institutions. I mean, even our students that we got hold of them, many of them are in very rural areas situated. The challenge for us as a university, I think Mrs. Swanepoel mentioned that, we had to print hard copies and get it to them one or other way. The university bought computers to laptops to issue students, and eventually, as you mentioned, some of the professors, the lecturing staff here also had to learn how this methodologies work to get on it. We were sitting here online and teach and being taught internally as well by our IT people. What the hell do you mean? You know, you could suddenly start talking to people, and eventually it happened very fast. Within a month or two, we were there, and a lot of tears that went along with that as well. You know, frustrated people and frustrated students and scared people. That was just the reality in South Africa, and I think for us here as well, where we handle these type of challenges. And I think it's an ideal thing that we can link up with a university like yours, and I hope we can extend this relationship into the future with issues that is challenging for us, you know, via our senior personnel and our students as well, that we can go and experience how things is done there, because we always say, you know, and you sometimes get the professional jealousy as well between different professions within a country. And now sometimes the jealousy as well between countries and so on. But I think the primary healthcare challenges is very similar globally. You know, and for one to learn, for us to learn from people that, you know, I always say, you know, we in Africa and South Africa as well should not go and try and redevelop a wheel that already exists. You know, we've got things like Codex and WHO, where a lot of guidelines is available for us. That is all along, and I mean, this experience was difficult. I think each individual sitting, especially here with us, knows somebody who passed away, nobody that suffered badly from COVID. It is real. And, you know, it is always difficult when we have issues like that. Guys, I think there's also maybe we can break for a convenient break as well, so long until the tea arrive. I just want to see what's the time exactly now. Yeah, it's 1:45. Let's make it until 10 past. We'll start 10 past again. Hopefully the tea and the scones arrive by that time. But the toilets are just outside here on the opposite of this door. So let's have a break and let's talk outside to those who wants to talk. Right. Hello, everybody. Welcome back after our tea break. I hope you are rested well now. Knowing students, they're always tired. Normally due to not the classes, but to last night's party. And I hope it is not the same. I don't want to generalize that's the same with you guys in the US. But I know when I see a student, you know, when that eyes just get vague and then they are there again, you just know that student wasn't behind the books last night. So they were at a party, and you know, then they fall asleep here. Guys, I want to introduce you to our next presenter. Now, this is a result of this institution's, one of my first students that was studying with me. Now you know how old am I? Very old. I saw some of my students refer to us as those oxygen thieves and things like that here during COVID and so on. But we're still there. Don't make a mistake. And Mr. Steyn, let me just put on my spectacles. His dad, when I arrived here, I knew him as well. His dad was the HOD at this metro. So he followed in the footsteps of his dad as well. He started with us in 1993. At those days, we were still a diploma course and known as Port Elizabeth Technikon. He finished his studies in 1995 with us. That next year, on the 3rd of January 1996, he started his career as Environmental Health Officer at the then Port Elizabeth Municipality. This is now this Kobega that you guys are training to pronounce, some of us as well. As a junior Environmental Health Officer, while furthering his studies with a 4th-year degree part-time at the then Port Elizabeth Technikon. In the year 2000, he joined the Amalgamated Transitional Local Council, which became the Nelson Mandela Metropolitan Municipality at that stage, today known as the Nelson Mandela Bay Municipality. They like to change names in this South Africa. You must just wink your eyes and you've got another name here. Watch out. In 2002, he progressed to the position of Senior Environmental Health Officer. For the next 16 years, he acted as a Senior Environmental Health Officer at the Nelson Mandela Bay Municipality. Currently, he holds the position of Acting Manager Environmental Health, Managing Health Sub-District in the Metro, and Mr. Steyn currently has 27 years work experience. He has also served on the management structures of the South African Institute, which I know he plays a very important role with, of environmental health, also at local, provincial and national structures. He's quite involved nationally. And the latter position being that of National Treasurer. I also know Mr. Steyn myself, where we arrange numerous provincial, national workshops, always a big part of that organization group with contacts and so on that is nationally involved and provisionally involved within the profession. Thank you for that, Dirk. And Mr. Steyn will now be presenting on the environmental health services rendered by the Nelson Mandela Bay Municipality so that you can get a clear idea on what's happening practically with our students that's been training here and the work that they will conduct when they work out here. But remember, one thing is, that is also your true learning school when your foundations has been formed in your tertiary institutions, which you will do and which comes with experience, as Mr. Steyn's got. Mr. Steyn, Dirk, dankie. Thanks. And Robert, thanks for that Afrikaans greeting this morning when you saw me outside. That's why I said it in Afrikaans now.
Okay. I don't know what the time is. Good afternoon. I'll start there. Thanks, Willem, for introducing me. yeah, people going on about age, I only look that old. I happen to think to myself, I'm not that old. I'm 48 years old now, so I'm not trying to be an oxygen thief, students. But as I always tell the students, you know, being an environmental health practitioner in this country is more of a calling than anything else. It's not a job. It's a profession, and it is a profession that you embark on as a caring person. Most of the EHPs that I work with, or all of them, you know, there are people that care for other people's health, people that cannot afford the luxuries that some of us can afford for going to a private hospital or seeing a doctor or something of that sort. So you're here for a reason, and just remember that. So as Willem said, I work for the local municipality. It's a metropolitan municipality here in, I'm still calling it Port Elizabeth. And I've been working here for 27 years, and I've seen a lot of things coming and going. But what I want to talk about today is exactly what it is that we do practically out there in the field, and what services do we render every day. Okay, so the South African health system is very complex. As was already mentioned by some of my colleagues, we've got 9 provinces in this country, each one of them a different color. We are right here at the bottom at the moment, at the end, Nelson Mandela Bay. It's one of the metros. And we've got about 6 or 7 metros in this country. Some of them claim they are metros, but yeah, they're not really metros. And then we've got 52 district health systems in this country. We are in this green one here. So we've got the 2 metros, which is Nelson Mandela Bay here in Port Elizabeth. And then slightly to the right is a B, Buffalo City Municipality. As you know, this is London. And then we've got 6 district municipalities. Consists of a larger geographical area, and you will find in each district there will be a lot of local municipalities, smaller towns like Jeffreys Bay, Humansdorp, St. Francis, and. And each and every one of those municipalities, district municipalities or metropolitan municipalities, as known, is a health sub-district on its own. Now, at national level, throughout the whole country, we've got our National Department of Health. They are more the policy makers, putting laws in place, SOPs, strategies, and all those kind of things. And at provincial level, you will find that you've got your hospitals and clinics and more of your curative services. But we also do have environmental health services at provincial level, but they're more dealing with port health and hazardous substances and things like that, and malaria control, which we fortunately don't have here. And then the municipalities are rendering a very specific on-the-ground, hands-on service. Okay, so the health services I've mentioned in South Africa is divided according to the Health Act into 4 divisions. You've got your curative health services, which you've got your rehabilitative health services, your EMS, your emergency health services, and then municipal health services. Those are the only 4 services that we, according to the health system, render in this country. Okay, so where do we come from? Just to explain more to the students. Obviously, we do not operate on our own little corner here on the earth. We have to fit in somewhere globally and nationally. So Africa, being a member country of the United Nations, participate in all their goals and objectives. So, I mean, the United Nations has got 17 Sustainable Development Goals. And if you closely look at them, they cross-cut through, all of them cross-cut somehow through environmental health. But the most important goal that we work with at this stage is obviously Goal 3, which states that they ensure healthy lives and promote the well-being for all, at all stages. Not only your oxygen thieves, your children, everybody that stays in this country. And our Constitution makes very clear mention of that, to say that we provide an environment which is not harmful to the health and well-being, and for the protection of our environment, and to the benefit of the present and future generations, and so it goes on and on and on. By obviously putting in place legislation and any other reasonable measures to ensure that we guarantee the health of our people in this country. Section 27 says that everybody in this country, whether you're a South African or a foreigner or whatever you are, where you come from, everybody has the right to healthcare services. So we have to do that. And environmental health services are obviously the services right at the bottom, which are always missed by government. for some or other reason, whereby we do identification and evaluation and control of all factors in the environment which may cause people to become sick or negatively influence human health. Okay, and it goes on. Where do we specifically fit in as a municipality? The Constitution mentions specifically in Schedule 5, Part B, that municipal health services is an exclusive executive mandate of local government. Then to further on that, the National Health Act, which is in place, it's our parent or mother piece of legislation, whatever you want to call it, clearly defines municipal health services in Chapter 1. And you've seen this now. And some of my previous colleagues that spoke now just mentioned the same thing, but in the definition itself, we deal with water quality monitoring, food control, waste management, health surveillance of premises, which is quite an extensive area, surveillance and prevention of communicable diseases, excluding immunizations. We used to do it, but we're not allowed to do it anymore. That's why we're for nurses. Vector control, environmental pollution control, disposal of the dead is still defined like that instead of management of human remains, and chemical safety. But as I've mentioned previously, it excludes port health, it excludes malaria control and control of hazardous substances, which is a function which is rendered at provincial level by the environmental health practitioners at that place. Now, to unpack each of one of those aspects in the definition in the Health Act, the national government has developed a regulation under the Health Professions Act called the Scope of Profession, and each one of those are unpacked, each KPA, each key performance area is unpacked in that document. Okay. These are things that we are physically busy with every day on the ground. So we do water quality monitoring in the city, although we do not have a lot of water at this stage in the city due to the drought. But it makes it more interesting. It's one thing taking water quality samples, and every week you see the same things, the water is fine, there's no, all the chemical parameters are in place, all your bacteriological, micro, everything's in place, but all of a sudden you're sitting with a drought. And all of a sudden everything changes. So you have to start thinking for a change, instead of just sitting there and piling up your stats. And if you look at your drinking water, in this metro we've got 77 points that we physically take water samples at taps in the community. We do biological samples and chemical samples. The same goes for recreational water, where we do, for example, swimming pools. All our swimming pools, for instance, at accommodation establishments like the hotels and at schools, we do monitor that as well. River water, which is or surface water, whatever you want to call it, is a big problem at the moment due to failing infrastructure. The water is heavily polluted in most instances due to sewage spills into the water. And in South Africa, there's a tendency, especially with the younger kids, they love playing in rivers. Whether they're flooded or not, they play in them. We've got religious rituals that take place in river water. And who's going to warn those people about E. coli levels? And I'm talking E. coli levels well in advance of 2 million. So it's not just a small little thing. So it's our job to monitor this and to put warning systems in place for the public itself. Coastal water, the same thing. As well as our wastewater. Wastewater is very interesting because at the moment we've got a couple of programs running in our wastewater sampling. We're still continuing with the COVID RNA sampling at all 7 our plants. And it's funny, although COVID is now not more a pandemic, but if you look at the levels of RNA that we are currently receiving in the water is at level 3. I'm not going to talk quantities now, but the maximum level that we had at one stage was 5. And they're all averaging still at 3. So somewhere along the line, people are either not testing for COVID anymore, or they're so immune to COVID because of booster injections and what have you, that it doesn't affect their lives anymore. But it's still out there, it's real. We also have a cholera sampling program in place at our wastewater plants. Funny enough, we do not pick up cholera, thank you. I'm very happy about that, but we do pick up all the other Vibrio species. And if you look at the statistics from the Department of Health, there's no mention anywhere in any hospital of people being infected by Vibrio species of that kind. So our next step is now obviously we're monitoring factories. We've got a lot, we're on the coast, we've got a lot of fish plants, fishing plants, or what do you call them, fishing, manufacturing plants and processing plants. So we're busy monitoring them and see where their wastewater is going into and how they manage their wastewater, because unfortunately, as I say, infrastructure is a problem. Our wastewater plants are not that effective. And some of the water, at the end of the day, the effluent runs back into the sea or into the rivers after it's been treated. And who knows whatever comes out there on that side. So we're doing that monitoring on that side as well, just to safeguard the system. And at the same time, with the university, we're also busy doing the antibiotic-resistant microbes at the inlets and outlets of the plants to see what effect the treatment plants have on those kind of microbes and exactly what the end result will be for the public. Food control, straightforward. I think it's the same in all countries, where we ensure obviously safe food for everybody. Evaluation of food handling premises, which is a straightforward function of any environmental health practitioner. We also do the evaluation of informal food vendors, which is a massive problem in this country because everybody's trying to make money. Everybody's pitching camp everywhere and just selling food and preparing food wherever they can find a spot. Taking of food samples, also a critical function that we have, because we have a lot of people in this country that try their hand at manufacturing food, and they've got absolutely no idea what they're doing. You can imagine the nightmare that will be at the end of the day. And going with that, obviously, is the labeling of those food products, because we find a lot of products that are not even labeled. And we are starting to find problems with people consuming some of this food, and some of the colorants and all the other chemicals are not listed on the labels, and people become sick. Who sues who? Because whose responsibility is it to ensure that people know about these things? Then waste management. Waste management side of things. In this municipality, we're a big metro. We've got a specific, in public health, we've got a public health directorate, and in public health, we've got also, besides environmental health, we've got a waste management sub-directorate that specifically deals with the collection, the transport, and the final disposal of waste. In that directorate, we also have 2 environmental health practitioners appointed, managing that whole section. And then environmental health will be on the side. Where we come in is obviously when it comes to private businesses and big manufacturing plants, to ensure that they also have proper storage, handling and disposal of their waste, especially in multi-residential units like blocks of flats and those places, because some of the waste are removed by private contractors and not by the municipality. So we ensure that those contracts are also in place. Obviously advocating proper sanitation in communities. In South Africa, we've got a vast difference between people staying in a formal housing development and people staying in informal housing development. The informal side of things, I'm not going to lie about it, it's currently a nightmare. And we've been busy trying to put programs in place to try and reduce the volumes of waste being dumped indiscriminately in our communities. And it all comes down to mindset. Education and education and education. Going out with various health education problems, and my colleague Tembi will talk about that a bit later. But obviously, as you go along over the years, it doesn't make a major impact. So there's, for the students, seeing that you, what did you call yourself? Yeah, young-minded. There's an opportunity for you there to deal with, because I think we're sitting with a very unique situation in this country. There's not a lot of other countries, developed countries. We're obviously a developing country, although some people think we are developed, that sits with that kind of problem. And it's really a challenge to us. But Tembi will speak more about that. Health surveillance of premises. In terms of the Health Act of this country, they developed a specific regulation for environmental health norms and standards as far as premises are concerned. It includes anything from a creche to an old age home, frail care, schools, prisons, holding cells, office accommodation, residential accommodation like your hotels and things like that, that has to be evaluated. Obviously, we're also involved with environmental health impact assessments with developments in the city. We also do assessments of ventilation, lighting, indoor air quality, overcrowding, and so forth in buildings and at businesses as well. And then assessing all public transport facilities, although I must be honest, we don't do that a lot. But when we do have the chance, we do that as well. And then obviously in general, assessing premises which might pose a public health nuisance in general to the communities. Then surveillance and prevention of communicable diseases, which is something I like very much. I've spoken about it before. We've got our water quality sampling programs in place, especially now with the drought. We'll be battling with E. coli and in coliforms in water. We are also running, as I said, our wastewater surveillance programs at the moment. We've got our air quality monitoring programs in place. And we also have plague surveillance in place in our Kuga IDZ, it's an industrial development zone at the international port as you come in from the northeastern side of the city. And I don't know why they built a port smack bang in the middle of an endemic plague area, but with the drought that we are having now, we're seeing the movement of rodents going two ways, either towards the community where they can find food because we're sitting with a sanitation problem in the informal housing settlement. And on this side, we also have all the food factories, Lactalis, Mondelez, you name it, they're all on this side. So the rodents are busy migrating to either side of the industrial development zone. And unfortunately, there's humans. So, you know, it's something that has to be managed. But try and explain that to a politician anyway. So we go out there, we do our assessments, we do our evaluations, we try and put control measures in place. We do the collecting of the data, the analysis of it, the dissemination of all our epidemiological data and information that we find, because there's no use sitting with it. You have to present this to the decision makers, the guys who give you the money to do the work, that you can get more resources to put more progressive programs in place. Zikla? Okay, I think I've spoken about this. I'm not going to go on about epidemics, emergencies, and diseases. Okay? Thank you. Vector control, obviously identifying vectors, their habitats, breeding places, try and eliminate it as far as possible. This is an old city. I think it dates back to 1820, if I'm not missing. So we've got a massive challenge on our hands as far as rodent control is concerned in the city. We're also sitting with zoonotic diseases. As I said, we have plague. Something that stuck its head out last year was rabies. We have a massive influx of rabies, especially in the northern parts of our city. And we're also sitting with bilharzia, of all things, in our Kariga district, in the old Uitenhage, whereby we first saw the first few cases. We thought, okay, fine, because there's a lot of travel up and down between Mozambique, Malawi, and South Africa. But then we started finding new infections in the area, in one of those rivers there. So we're busy currently doing surveillance there as well. And, you know, it's staying on the southern part of a country, which is not supposed to be a warm area. You all of a sudden start finding all these emerging diseases from tropical areas, which is something which is very interesting, but staying in an area where it's not supposed to be, it's challenging at sometimes. Okay, pollution control. Obviously, it speaks for itself in our living, working, and recreational environments. We do a lot of, as I said, monitoring of rivers. We've got a lot of industries on our riverbanks, tanneries, manganese ore plants, and so forth and so on. So we do a lot of monitoring of that as well. Dust pollution, SO2, your NOxes, all of those. We've got programs and monitoring stations in place, which we actually got from Gothenburg local authority, the knowledge and the know-how from Sweden and how to do that. We're also starting to doing radiation and non-ionizing radiation measurements here and there. It's just in the testing phase. So we're trying to do that as well. And soil pollution, water pollution, air pollution is our main thing when it comes to pollution control. So as I say, the infrastructure is failing us, and you have your days at end trying to convince the decision makers to put measures in place to curb it. But yeah, I'll speak about that a bit later. I've spoken about the air pollution and so forth. Willem, you can skip this one, please. Okay, disposal of the dead. Not a nice word. The regulation now calls it management of human remains. Obviously, where the EHPs get involved in the permitting, the licensing and health certification of your funeral parlors, mortuaries, where the facilities where they store the bodies, especially with load shedding now, it's a major problem in our country. We also have to monitor the practices at the cemeteries and the crematoria. We have a lot of exhumations in our country, especially in this city, and it is quite challenging, you know, because it's a whole mindset change, because not all cultures do exhumations. So as people move, they take their family with them. So that is also regulated by us. Chemical safety at this stage, we find a lot of chemicals being sold on our streets, which is actually, number one, illegal in this country. Funny enough, most of them are imported from China. And they're selling it on the streets. And kids get hold of these poisons. They don't know what it is. They drink it or they ingest it, they eat it, and they die. Obviously, there's a permitting and licensing, auditing of all these premises that store these chemicals. And then obviously in the communities itself, we facilitate a lot of advice and education and training on pesticides and chemical safety. We've recently had a case whereby kids in a certain community all started getting sick. They started vomiting after ingestion, eating what you call those crisps, chips, extruded maize snacks. And everybody ran to the factory. I said to them, guys, what do you want to do at the factory? Because this is the only area where they buy the stuff and they get sick. The rest of the city is fine. I said, go and check what's stored next to the chips. So eventually they found out that the pesticides and things are stored right next to the chips. People touch these pesticides and poisons, which are obviously decanted. They're not sealed correctly, not labeled correctly. They take the chips, they eat it, they lick their hands, and that's how they got sick. And yeah. So fortunately for the factory, he got away with it because he was running around like crazy and thinking he's at fault. So those are the kind of things in this country that we have to educate people on. It sounds simple and it sounds ridiculous, but those are the kind of things that we have to still do in this country. People do not understand the concept of something like that. Noise control, also something which is, in my opinion, not given a lot of attention to, especially when it comes to developments. People building highways and byways right through the middle of suburbs without even thinking about things like noise control, putting up factories amongst residential units. And then obviously there is your everyday noise polluters, your nightclubs, your events and whatever you're going to have, whereby we've got our noise control guys in place every time, working with the sound engineers, working with industry, to see how we can reduce noise in workplaces and in residential areas. Obviously, so it doesn't have a negative effect on the residents and the people attending all these events. And I think more or less that's it. I don't want to bore you much more with what we do. Tembi is going into detail about the COVIDs and this and that, to the specifics of what we are currently doing. So thank you. I don't know if there's any questions at this stage. Yeah.
So we've been out in Michiondale and out in the locations, and you mentioned that waste disposal is
indiscriminate.
What needs to be done? How can that be done? The waste disposal in the locations, how can that be solved?
I'm going to gossip now. So whatever I say must stay in this room. Yeah. It's a problem to us because as environmental health practitioners at this stage, the biggest budget for waste is going to the waste management side. We can come up with all these beautiful plans and education drives and whatever it is that we want to do. Most of the money is moved to collection, disposal. That's it. Collection, transport, and disposal. That's all. That's how they see waste management in the city.
That's not you.
That's not us. You see, that's the problem. They've got a separate waste management department, which used to fall under the engineering services. They collect, they transport, and they dump. On top of that, and you must remember, in a residential area like Mission Vale, they've got a weekly service running. The trucks running through the streets, picking up the refuse at the houses. For businesses in the same area, they do a bi-weekly collection. So that's now 1 to 3 times they go through that area. On top of that, they have what they call a cooperative arrangement, whereby they employ people, I suppose, from the local community, who's got their own little cooperative company, and they are in charge of picking up any waste that was left behind, like the illegal dumping and. You were there. Tell me it's working. So obviously, and that is what the two of us have been talking about, somewhere along the line there's something wrong. Because you must remember they get paid per volume. Now why would you want to take your own food off the streets if you can just keep on going and fetching and fetching and fetching and fetching? And that is something that the two of us have been battling with our colleagues in the other department. And it's my personal opinion, it's a cash cow. It's money. Why would you take your own money off the streets? And as long as the political mindset, in my opinion, this is not the department's opinion, as long as the mindset of politicians change as far as this is concerned and start putting stricter control measures in place and speak to their own communities because they're elected to represent those communities and they're the same people complaining to us. So it's a vicious circle. So that is a challenge that we are sitting with. And it's not only in Mission Vale, it's all over the city. All over the city. People just simply do not have the means like we have in the more affluent areas to dispose of waste at the transfer station. There is no transfer station. You don't want to keep your waste in your backyard. Where are you going to dump it on the first public place that you can find? And you know the municipality will eventually come around and pick it up. Only to find yourself next week in the same situation. We've cleaned areas in an hour's time that we take 4 8-ton tipper trucks and we fill them with TLBs. We fill them, we plant grass, within 3 hours we plant trees, we create a beautiful park. While we are busy working there, people come there with their trolleys and the carts and they start dumping there. We'll be busy planting grass, planting trees, cleaning. They just keep on dumping. So it's that whole mindset, that educational side of things. And we try and target it at school level already, where we have all these campaigns at the primary schools especially, to try and change that mindset of people to not just dump, because there's a lot of obvious repercussions to that as far as health is concerned. So I know I haven't answered you, I haven't given you an answer as to what, but that is the situation that we currently find ourselves in.
Thank you, Dirk. I would allow 2 more questions maximum, and 5 counts. 1, 2, 3. Dr. Amrup, you've got the prize.
Thanks. Bob, I think just to also add to what Dirk has mentioned regarding the refuse removal, you need to understand the context, where the informal areas and where the rural areas have come from. They traditionally did not have a refuse removal service. Okay, so that's something to bear in mind. And still, a lot of the rural areas do not have. So where you went to in Mission Vale is like a township. You perhaps got services there, but if you go down into the Transkei areas and so forth, you're not going to get services there. Now, in the areas of Mission Vale, as what Dirk mentioned is true, they try to form some sort of partnerships and it does not work. It does not work for the simple reason there is no commitment from leadership, and that is where the problem is. Because there is an easy solution, and the solution is working in other parts of the country, where you work on the transfer station system, where you work on the communities. So you'll get a community person that lives in the area who's got a bakkie. He or she will make sure they will pick the refuse up on a specific day, take it to a specific spot. From there, the municipality will take it. But all that needs to be controlled. And if it's not controlled, and exactly what Dirk said, that's where the problem is. So it's a lack of commitment. It's not a lack of systems. It's not a lack of ideas. They have got all the ideas and systems. It's just people do not want to do the job. And that is our problem. Thanks.
Don't know if you want to comment on that. A comment, Dirk. Here's another question from Prof. Mallariri.
Rather not, because then I'm trading on losing my job.
Yeah.
Thank you so much. Thank you so much for the presentation. I actually just got a slight indication of when you mentioned something about the vectors regarding schistosomiasis and water-related infections like that. I wanted to know, is it possible for us to have an idea of the water bodies that are infected? Because I do know that we collaborate, the faculty collaborates greatly with the Coastal Marine Research Institute, and a lot of work is being done on water and health. And of course, there are a few students working currently on schistosomiasis, and in fact, within this week, they were in the field trying to identify the vectors, but at times it will be more directed if we know the areas that are infected, and then the vectors could be identified. So it's just a call for more collaboration within, from the university side and that of the municipality, so we can actually, make informed inputs in that regards. Thank you.
Prof, if I may answer you now. The specific area that I'm talking about is in the upper parts of the Swartkops River. To explain to you is going to be difficult. I think I have to go and show you. It's an area where there used to be, for instance, there used to be a bridge, a walkway for the people to cross the river. It's not like the lower part of the Swartkops River that's wide. I think it's 5-6 meters wide. The water is actually more stagnant than anything else. But the bridge collapsed years ago. So the kids walk through that water on their way to school. They play in the water. They swim in the water. You know what it's like. They wash their clothes in the water. Everything is being done in the water. And that specific spot is where I know the euthanatic side of our department is busy dealing with that bilharzia issues over there. So I think the best would be for us to go and show you specifically where it is. Yeah, anytime. Oh, a pleasure.
I don't know, was that just a comment that Prof made there? Okay. Guys, just for the sake of time, I think I'm going to stop the questioning now. Thank you, Dirk, so much for your presentation. I think it gives an oversight of the work that the environmental health practitioner is involved with and had to deal with, and there's a tremendous amount of challenges as well when we deal with these issues. And as a university department, the Metro plays a vital role and in-service training of our students as well, where we place them around about 100 days during their 4 years of training. They had to do in-service training as well at institutions like that, at abattoirs, where they learn how to do meat inspections, and at various other places. So for the massive role that the Metro play and the environmental health services play related to our training as well of our students. Thank you, Dirk, so much for your presentation. It's appreciated. I'm going to ask the next chair, my colleague Cherise Brown, to take over and run the proceeding further. Thanks, Cherise.
Thank you to my predecessor, Mr. Michal from Namibia. If I can maybe just add that I was also one of Mr. Michal's students. So we've seen the previous speaker mentioning he's in his late 40s, am I correct, Dirk? I'm in my late 30s, so there's a whole a whole group of us that have gone through Mr. Michal's training. So thank you for that, Mr. Michal. Good afternoon, everyone. I'm Cherise Brown, and I today have the privilege of chairing the second session for this afternoon. So I'm hopeful that we are all a bit warmer at the moment, because I think in the morning it was extremely cold in this venue. I don't know if it was only me that was complaining about the temperature, but yeah, we've sort of adjusted that. Mr. Michal briefly touched base on work integrated learning, and that is something that our students have to do for at least 100 days in order for them to qualify at the end of their 4th year. So what we do is we have a working relationship with the municipality where we place these students there for a minimum of at least 100 days over the 4-year period. And they go out with the environmental health practitioners and they are mentored on a daily basis and they do exactly what is expected of them once they qualify. So the first speaker I have the privilege of introducing is Ms. Tembi Bly. She's very instrumental in arranging and coordinating that placement. And she works as an acting manager environmental health at Nelson Mandela Bay Municipality. She holds a degree in environmental health and an honors degree in sustainable development planning and management. She's worked as an EHP, which is short for environmental health practitioner, for 17 years in different municipalities. She worked for the City of Cape Town from 2006 to 2019, where she gained a lot of knowledge in the application of environmental health-related legislation. She worked in different community settings and encountered diverse cultures. Through her experience, she developed a range of skills. She left City of Cape Town and she came to our beautiful area, Gqeberha. So she's currently at the Nelson Mandela Bay Municipality, where she manages a planning section, and this section is mainly responsible for coordinating health and awareness initiatives within the metro. So they were very instrumental with the COVID-19 outbreak, and I think she's going to touch base on that. And because of her passion in the profession, she's actively involved in different environmental health-related forums and also the deputy chairperson of the South African Institute of Environmental Health in the Western region. She's a registered member of the HPCSA, which is the Health Professions Council of South Africa, and she will now be discussing the environmental issues impacting the health of populations and what the local authorities' response was in terms of COVID-19. So thank you. Over to you, Ms. Bly.
All right. Thank you so much, Cherise. Okay, let me stand at the block. Good afternoon, colleagues. As said, my name is Tembi Bly. I heard, Professor, that you are heading to Cape Town. When is it? Monday. Okay, you must enjoy the beautiful city of Cape Town. I spent half of my life in Cape Town, the most beautiful place ever. I'm not saying anything about our city, Gqeberha, but Cape Town is nice. All right, so I am going to be looking at the environmental issues impacting the health of populations. And what the briefing was as that we look within our city, which is the Nelson Mandela Bay Municipality. So my presentation will be purely focusing on that. But I feel that there isn't a lot that I'm going to say new. I think most of the stuff that I'm going to share with you has already been covered, particularly by my colleague Dirk Steyn. So please bear the repetition. So I'll try and quickly breeze through this presentation because I feel many issues have been touched on. You can just ask questions if you have, but then we will go to the COVID-19 one soon. All right. Okay. There we go, technology. What did I just do now? Did I? Okay. Yes, please. Okay, so that's just in terms of the content of the discussions today. looking at the introduction, the legal context, some of the environmental issues that are being experienced in our city, and there I've listed air pollution, noise pollution, water quality, land pollution, food safety, and some of the challenges that we are experiencing as the health sector in the country. So in terms of the introduction, environmental health as defined by the World Health Organization is those aspects of human health and diseases that are determined by the factors in the environment. So I thought it's very much important that we look at the definition of environmental health, because the environment that we live in determines the outcome of our health. So we look at the physical environment, the biological, social, chemical, and psychosocial factors within the environment. And the environment, it is anything and everything that is external to us. How then we interact as humans with the environment really does have an impact on the state of our health and well-being. Now, what does health mean? Because for different people, health means different things. But in terms of our profession, health means a complete state of social, physical, mental well-being, and not mere the absence of disease. And I think that is where mostly it is missed, where health is seen from the curative side of things and not from the preventative side. Most people recognize health when they go to hospital or clinic, but health starts in the environment where you live. You can proceed. In terms of the legislative context, Section 24 of the Constitution has already been said. Everyone is got a right to an environment that is not harmful to their health. That is what we live up to. And then we've got the National Health Act that Mr. Stein spoke about, that our Mother Act, and we've got a range of acts that we enforce in order to make sure that we are addressing the environmental health issues, so that we make sure that the health of our communities is well. So those is a range of acts: the National Environmental Management Act, the Environmental Conservation Act, Water Services Act. There's a whole lot of acts. And you will find that under each act, you can proceed, under each act, there is a range of regulations that are under each act. So we've got Mother Acts, and under each act, there's a set of regulations that we have to enforce in communities. So, okay. So in terms of the Nelson Mandela Bay municipality where we operate, Gqeberha in particular, that is one of the 8 metropolitans in South Africa, which is the biggest, one of the biggest municipality in South Africa. In the Eastern Cape, there's 2, as already mentioned by our previous presenter. We've got ourselves, and then we've got the Buffalo City, and we have a population of about 1.3 population. Our city, in particular, has the highest, one of the metropolitan with the highest levels of poverty. According to the statistics that I looked at, that dates back to 2016, more than 50% of our population lived below the poverty line, and there's high levels of unemployment within our city. So those are some of the challenges which I thought, before we can delve into the presentation, I need to highlight, so that you can understand some challenges that I will highlight at the end of the presentation. So some of the environmental issues that we have within our city is air pollution. Simply because we've got Durban as a city of eThekwini, I think, a city of Cape Town, and city of Johannesburg. And those cities are the ones that are mainly have got like your manufacturing, they've got a series of activities, even the port. Now, there has been, over the years, a slight development moving into our city in terms of the manufacturing. It is one of the largest economic sectors in the metro, one of the areas where that provides employment for our communities. And with the growth of the manufacturing sector, we have what we call the industries with listed activities. Now, listed activities in terms of the National Environmental Management Act, the NEMA Act, there are activities that are listed. If you've got listed activity, that simply means that you've got pollutants within the production that you may emit into the environment that has got a bad health impact. For instance, your NOx, your sulfur, and your carbon dioxide, and so on. So those are the industries that we are talking about due to their health related implications that they have on the environment and to our communities. And we've got controlled small boilers. Those are boilers that have got a potential to also emit into the environment, that our communities can inhale that air and get sick from it. And we have offensive trade. We've seen a growth. I think since 2019, when I arrived in the city, there's been a growth of manganese ore. We don't have the mines within our city, but the ore is coming from other provinces and it is being exported from our port. And that is one of the areas where we are struggling a lot. We are getting so much complaints of the ore because often the trade is non-compliant. The ore is in an open environment, it's litter blown, dust pollution, and so on and so forth. And that is one area that I think currently is very topical within our city. Everybody is trying to get their hands on deck in trying to address the matter. But obviously, as mentioned by other presenters, the issue of political involvement is also playing a big role in this area. But we are pushing through. And also one of the challenges, as mentioned, the waste, the burning of waste, as well as the biomass burning. We are surrounded by some of the agricultural areas just outside the city. Now, that is one other area that we have to control. And the vehicle emissions. I think Shirel did speak about the diesel testing in the vehicles. So in terms of the control measures that we are doing, what are we doing as the local authority to address some of those issues that I've highlighted? We enforce compliance through health authorizations. We authorize all the industries with listed activities. We issue them with the atmospheric emission license, which we also call an AEL. The industries are also required to update on the South African Atmospheric Emission Inventory and Licensing Portal on an annual basis, where they upload their pollutants and the limitations that they are measure when they measure. They are allowed. They are required to do specialist studies, and they need to upload on that system. Depending now on the severity of the pollutants that particular industry is emitting, they are required to periodically report on. Some industries report on an annual basis. Some industries report on a quarterly basis. It really varies. The license is valid for a period of 5 years, and after 5 years, the industry is required to do. They need to reapply, but within that 5-year period, they are expected to report on an annual basis on their pollutants. We also have the continuous measurement of the air pollution index within the city. We are making use of the Environment software system that we are using in our ambient air quality monitoring stations. So on a day in, a day out basis, continually we measure the level of PM10 within our city, the sulfur dioxide, carbon monoxide, nitrogen, as well as nitrogen. We also keep the database of controlled boilers, which the industry is also expected to report on the emissions on an annual basis. And the farmers, the farming community is required to make burning permits if they want to burn the biomass. they need to apply to us. They can't just ban. In terms of the offensive trade, which in this case is manganese ore, it is regulated under the norms and standards that are promulgated under the Health Act. So if they comply with all the requirements, we issue them with a health certificate, and the health certificate would usually come with conditions. For instance, there is a company that we issued with a health certificate, I think about a year back, and what then the company had done is that they had the storage on the other oven, and they had the loading on the other one, but they have since sold the storage area, which was then inspected and it was found compliant. Now the manganese ore is stored in an open environment. They do not cover. So what we are now currently doing is to really try and strengthen our law enforcement regime. In that regard, we will be taking some of these companies to court. So that is what we are currently working on, with the hope that we may have possible prosecutions. But we know how law can be, so we are really wanting to try it out and see how far that is going to take us. But we are very wary of what can happen. And then we've got noise pollution, which is one of the areas that is affecting the health of our community. I remember when I started working as an EHP, I got this noise complaint. It was a church, this charismatic church is making noise, playing pianos, and the lady that was complaining at the time had depression because of the noise. So noise has got very severe health implications on health, and usually we get the noise from your nightclubs, your social events. In terms of what we do, if you're going to have a church event, be it is an overnight prayer, a social event where there's artists gathered in a stadium also, as well as the nightclub, we issue noise control permits. That's how we control the issue of the noise in the city. In the permit, we take into consideration the surrounding environment. Who is in the environment, the built environment? We recently had an event at the stadium where there were hospitals around St. George's. So we had to take into consideration that there was a hospital, so we limit the times of the event. The event organizer wanted to go up until 1 o'clock in the early hours of the morning, but we limited the time to 10 o'clock because we had to take into consideration that there were residential areas around the stadium. And throughout the event, we measure the level of the noise and we liaise with the sound engineer, the event organizers, just to make sure that it is at the decibels that we have recommended. So anything above, after 10 o'clock at night, we reduce the decibels to 60. Before that, we remain at 85. The water quality, Mr. Stein has spoken about this one, but what I want to highlight, was it last year or year before last, where we had water problems in our city. Mainly because of the drought, it's becoming rather very difficult to treat our water. The drought has been the major problem, as well as the aging infrastructure. It is one of the challenges that we are having. In terms of the aesthetics, we've had many complaints, communities complaining about water coming out of the tap in a brownish color. So it's been a really struggle in terms of our quality as a result of the drought. But we do monitor our water on a weekly basis, as mentioned earlier. We really pay special attention to your microbial as well as your chemical compliance. So what happens when a sample fails, we resample. When the resample fails again, we issue public warnings. So that is what we have as a system, just to inform the members of the public. I remember when we had, I think last year or year before, we had E. coli in our water, and there was quite a number of people that were affected, and therefore the municipality was taken into task by different organizations, social organizations, and so on. And last I checked, there was a court case where the municipality, the members of the public, or rather the organizations, were asking, what did the municipality do? How did we inform the members of the public? We use different mediums of communication. We use your social media platforms. We use the radio stations, the local radio stations. We use the newspaper. We try to reach the community on an online system. But it becomes, again, a challenge where half of the population might not have data to even see that information. How do you reach now the lowest, for the lack of the better word, member of the community? They don't have TV, they don't have data, they don't have access to the internet. So it becomes a challenge where we have to go to physically go to communities and loud hail in some cases, just to prove that we have done the education that we needed to do. That has already been covered. You can proceed. Okay, land pollution. Again, this issue has already been spoken about. When Professor was asking about waste, I was like, oh, he's going to do my presentation now, but but okay. So I always say, you know, we have a challenge with modernization, urbanization, you want to call it anything. I think also Professor Ramrud did allude to this. We have a number of communities or people that are moving onto the city for better opportunities, whatever opportunity, because in the rural areas are often neglected. There are no opportunities for education, for instance. There are no opportunities for employment. So what people think is that, let me move on to the city so that, you know, my children can have better access to education and employment. So that has, the rise in the number of people that are moving into the city has generated a large amount of waste that is generated at household level. Within the city, we've got 2 landfill sites, which are almost full. Now, what is currently happening within the city is that we are having different initiatives of trying to reduce the amount of waste that is going on to the landfill. We have embarked on different programs. Oh, it's a lot of programs. But the current one that is currently running is where we are educating communities on the recycling initiatives, how then they can reduce the waste that goes to the landfill site, where recyclables are put on one side and then the waste that cannot be recycled goes to the landfill site. The project is being piloted in one of the areas within the city, and I think it has gone very well, where the city has recovered an amount of recyclables. But one of the challenges that we are having is that we do not have recycling facilities within the city. So all the waste that gets collected here, it needs to go to East London. So we are wanting to work with the private sector, where we can create an enabling environment for the members of the public to recycle. And one other challenge, we have done also a study on why people are not recycling if they had an interest on recycling. And one of the things that came very strongly is that, remember I said initially that we have a high rate of poverty and unemployment. Now, our citizens, they believe in being paid for everything. Now, they don't want to recycle at home because they feel if they recycle and give the waste to someone who is a known recycling company, that person is making an income out of their waste. So that is just one of those things that we need to continually educate on and eventually change the mindset, because it's not like that, but that is what they believe. So we've got a very low interest, especially in the lower areas of the city, where members of the public are just not interested to recycle. but we are making progress in other areas of the city. The other thing that is making matters worse when it comes to waste, is the informal trading. Like it was said, everyone sees an opportunity, especially after COVID. A lot of our communities lost their jobs. Therefore, they are resorting to something that they're familiar with, that they know how to make, which is food. And often the areas that they stand are not serviced, that they trade on are not serviced. It's just a vacant land which had no intentions of being serviced. There's no waste collection, there's no water. So it also becomes a challenge, because then once they move into that land, then the dumping problem starts. We've got the waste challenge attracts the rodents, the flies, as well as the bad odor. We've heard that our city is plague prone. Now, with the challenges of waste that we are having, that we are experiencing, we are really scared that we are attracting a number of rodents into where people stay. But we do have the plague surveillance program that is currently running. And the last rodent that was found positive was only in 1982. So this is a good sign, but we have to continue monitoring that. The blocked sewages is also a problem caused by litter-blown waste. We often have blockages of drains everywhere. So that's just one of the problems that we have. The mushrooming of informal settlements, again, they moved onto the land that is not earmarked for a housing development. There's no servicing of that. There's no waste collection service. So what do? Then they dump onto into any other open space. So that has already been said, but what I want to highlight is the point at the bottom. In terms of education and awareness campaigns, we have particularly responsible for coordinating education and awareness campaigns with the city. With the intention of behavioral change, it has been rather a very difficult task. We have had projects naming them different campaigns, giving them different names. We've had source separation project, the one that is currently running, the Clean My City campaign, the Love Where You Live initiative. We have had many initiatives where we want to involve the members of the public to become part of the solution. But not a lot has yielded from that. But we have some spaces that have been permanently cleaned as a result of these campaigns. The drought, which is currently one of the challenges that we have, it is really threatening our food security in the city. If I can just give you an example that when I started within the city in 2019, we had about 20 farmers, 20 dairy farmers, but to date we are sitting at less than 10. The farmers are moving their head, they're selling their head because of the drought. They're not producing the amount of the volumes of milk that they used to produce because of drought. When it rains, normally a healthy herd will produce about 50 liters of milk. And currently we are sitting at 30 and less, which is affecting the farmers. It is becoming very difficult for the farmers to keep up with the feed because they have to buy, there's no grass, there's nowhere to feed these animals. And also this health status of the herd is being affected. We have had quite a number of cases where our herd has had the mastitis. We've had few cases of brucellosis. We've had few cases of TB. So, you know, because the city also it depends a lot on the exports. We are exporting a lot of milk to Dubai, to USA, and so forth. Now the export is decreasing slowly but slowly. And one other thing that I've noticed, if you walk into our retail stores, you will find 1 or 2 brands of milk. One of the reasons is because there's just not enough milk within our city. The Eastern Cape as a whole produces about 80% of milk that gets distributed around the country, but all that milk comes into our city to be treated because the biggest heat treatment dairies there within our city. We're not treating as much milk as we used to, and the quality of milk that comes in is very compromised. We have had cases where we also find antibiotics in that milk, and if we find antibiotics, we have to dispose. We have to tell the farmer to dispose the entire consignment. So on a monthly basis, we do surveillance of the milking sheds. We do the daily sampling program of raw as well as pasteurized. We liaise with the Department of Agriculture, the state vets that are assisting us in terms of making sure that our herd are certified. We require an annual certification of the health status of the herd in terms of the tuberculosis as well as brucellosis, just to make sure that our herd is healthy. But one of the challenges that we have is the informal farming, which is very big in the city. Now, that herd is uncontrolled, is not registered, we cannot control it. And there is also a rise in sale of raw milk. Our community, once again, is poverty-stricken, and instead of going to the shop to buy amasi, you'd rather go to the informal trader for raw milk, which is often not very healthy, stored under unhealthy conditions. You don't know the health status of the herd, so there's a huge risk that comes with it. So for food safety is I thought I must just highlight some of the challenges that we have when it comes to food. Over the years, we have had a number of foreign national shops. It is one of the biggest challenges. They do not want to comply to our laws. They don't understand our laws. There's nothing that they want to do in terms of making sure that their premises comply with the standards. They are not certified. This is an area where we are really struggling. We have found a lot of counterfeit food products in the market with no labeling in a lot of cases, or if there is labeling, it's in a language that you cannot understand. They can also not speak English, so it is even hard to communicate with them. So this is one of the things that we are really struggling at, and it is compromising the health of our communities, because often these foodstuff products are affordable. You'll find a can of beans that is 5 rand, and then if you go to a supermarket, the local retailers, you find a can of beans for 12 rand. So which one would then a community member go for? It's the 5 rand can. And we are running a sampling program where we take this foodstuff for chemical analysis, and we get high levels of preservatives, and we know with preservatives there's high risk of cancer, and we have seen a growth of cancer within our communities as well. So there's a lot of things that can be attributing to that, but food is mainly the biggest challenge. The informal trading is one of also the biggest challenges that's highlighted, the infrastructural challenges. There's often no cooling measures on site. There's nothing. The food is on an open environment, warm, is kept warm. But what we do, we make sure that we educate. Hopefully we will get somewhere. We are also strengthening our food sampling regime. And we are collaborating with other stakeholders such as Home Affairs, especially in the issue of national foreigners. And we, as highlighted earlier, that we want to make sure that we are strengthening our law enforcement regime. Now, if we look at the challenges that we are experiencing, there is a constitutional right that we have to deliver to our citizens. And there's a reality on the ground that our communities they live in poverty. Now, the multi-sectoral approach in addressing environmental issues is a challenge. As an environmental practitioner, you are mostly, I would say, the middleman between the fixer and the aggrieved. So the community members complain, but you do not have capabilities to fix. Perhaps it's an engineer that needs to work on the problem, a waste manager, whatever. But there's often that relationship that you need to build with other departments, which often is not easy because people have got their own mandates and they feel sometimes that they do not report to you, so you do not have the right to tell them what to do. So the reality is that we are the middlemen. There's a community, there's us, as well as the other department. So what we do, we always advocate on behalf of those that are voiceless to make sure that they get the services that they deserve. The economic growth of the city versus enforcement. One of the challenges, again, as mentioned, we've got a huge challenge of the manganese ore, but it provides high number of employment to our citizens. Now, you need to balance compliance and the reality of the communities. Many families depend on that person that comes with an income. If you close the company down or you close the business down, you're literally taking away an income for other 5 family members that are dependent on that one community member. Those are some of the challenges. And merely, I'm just highlighting the complexities in balancing the environment and health. Because we said earlier that health is a state of well-being. It's not just the mere absence of disease. But if the environment where our communities live have got waste, drains are blocked, there's air pollution, and so on and so forth, how do we then try and balance it out? It's very complex. It's got political challenges and a whole lot of other challenges that were mentioned. It's not easy areas to navigate and make sure that the citizens do get their constitutional right. Lastly, the funding of the health sector, which is often very skewed. Health is seen as curative most of the time, and I feel that if the government can invest more on preventative, the health of our communities will be far better. Thank you.
Thank you so much, Thembi. Can I open the floor for a few questions? Thank you.
Thank you so much for the presentation, Mrs. Bly. I have one question and a comment. I feel like the question is just general with regards to drought as an issue to food security. So yesterday I was on a call with my mom. She's situated in Johannesburg. So she asked me to buy something for myself that is similar to what she bought with regards to food. It was a food item. And when I told her of the fact that the amount is not the same due to the money she sent me, she was surprised. So my question was going to be, is drought one of the reasons on why food is so expensive in PE? Or it could be probably the positioning of the city with regards to where we are, maybe depending on the fact that other products are not produced here or whatever. So I just wanted to know about that. And also I just wanted to comment on food safety, especially the control as education. Yesterday we were having a class with Mr. Michał and we were speaking about the importance of educating and especially educating the public, the consumers with regards to food safety and all of that. The reason why we were saying it's vital more than the people who are actually producers was the fact that we know that majority of the time the producers know of the rules and regulations, but they break them anyways. And the reason why we're speaking about this, this discussion started with a question we had with regards to canned foods and how if a can is dented, it's not supposed to be sold. And we're speaking about the fact that in the shops they do it anyways, but it's good to let the consumers know of such things so that when they get to the shops, they don't buy such food, and also they report such things. So yeah, thank you.
Okay, thank you. With regards to the first one, I think it's many things that may affect the food prices within the city. We import a lot of food because of the drought. Our agricultural land, the farmers do not produce as much as they used to. So there isn't much food being made within the city. So we bring into also the rising, the milk industry is hit hard. So there's a lot of things. There's load shedding. So we import, there's load shedding. So there's a lot of things that are currently happening. So I think it may be quite a number of challenges that we are experiencing, but the drought is certainly one of them.
Thank you so much. We've got another question or comment from...
Thank you so much. I wanted to ask, I picked up a point from control measures of land pollution, like through educational campaigns. I wanted to ask, how successful are your campaigns, like through education?
To a certain extent, they're successful, but the challenge that we have is the sustainability of the campaigns. Remember, we are only few EHPs with a whole lot of, in terms of the scope of work, as you have seen, that we need to deliver on a daily basis. I think if we were to have sustainable programs within our communities, we would reach somewhere. Like I said earlier, we have had sports where because of one campaign that we have had, they are still clean even today. So I think we can get somewhere, but the resources are not allowing.
Okay, so don't you think, Ms. Bly, if you can intensify the collaboration that you have with the university, taking the students, have students facilitating those campaigns, don't you think those campaigns they will be much more successful if you can intensify the collaboration between the municipality and the university?
Now that's a good suggestion. We
Thank
will
you so much.
Be in touch with the head of the department. Thank you.
Thank you so much. I'm going to open the floor for 2 final questions because there's a slight change in the program, but I will explain.
Thank you, Mrs. Brown. You are very strict, Mrs. Brown. Thanks, Tammy, for the presentation. Just 2 comments from my side. The Omasi, why they don't buy it from the shops and buy it from the rural areas? It's actually better. And can you hear? Yeah, because here they make the import, yeah, and they like it from the farm, okay. And that's something that they need to try because it's good food. Regarding the dust, I just want to say I'm glad to inform you that I have got a group of 9 students and we are doing some monitoring outside the manganese store. So perhaps by the end of this year, you'll get some results, both the total dust count and also the concentration of manganese. So let's see what we're going to find. Okay, good.
Thank you so much, Prof. In terms of Amasi, in our city, we don't allow raw milk. It's not allowed because of the risk attached to it. But we're looking forward to the results of the study. It's really going to assist us in a great deal. All right, let's move to COVID.
Any more questions?
We will combine with COVID.
Okay, thank you.
Because I think I only have 10 minutes, so that I quickly want to rush through this presentation. So what we did during COVID, we quickly formulated a response plan. We had to let go of everything that we're doing on a daily basis. And in that, we formulated work streams. Now, what we did in the work streams, now this is COVID that at community level. In the city, there is district health, and the district does have an outbreak response team, which we are also part of. But what then happened at that time, each and every profession had to find itself, because there were a lot of uncertainties, not everyone knew and understood. So all the professions had to teach themselves on how would then they respond to COVID-19. So what we basically did is we looked at the scope of practice, as seen in the presentation by Dirk. That is our scope of practice. So the areas that are highlighted in red are the areas that we used to respond to COVID-19. So we assessed what could be the risk areas, what we needed to do, which areas would exacerbate the number of cases within the city, what are the preventative measures that we could apply in each and every one of those areas in terms of the scope of work, of practice. We did surveillance of premises. I'm not going to bore you much with that, because I think that is what Mr. Stein spoke about. But we know that at that time, there were different levels. There was level 1 where there was total lockdown, level 2 partial, level 3, and so on and so forth. During level 1, we responded differently. During level 2, in all levels, we had to then come back to the drawing table and replan on how we would then respond. In the health surveillance of premises during lockdown level 1, we basically were just doing decontamination. The buildings at the municipality were closed. It was just only us that were at work. So we had to then procure so many liters of the decontaminants, sanitizer, and the spray pumps and so on. We were decontaminating the municipal buildings, the provincial buildings, the taxi ranks, everywhere. That is just the only things that we're doing. As the level progressed, we then, because people wanted to gather, we then identify the high-risk premises in terms of the number of cases that we were getting. Now, I will show you during contact tracing what we did, but then during contact tracing assisted us in terms of identify the high-risk premises that at the time were propelling the spread of cases within our city. So those are some of the premises that we identify: old age homes, higher institution learning, the schools, because this presentation was done in level 3, and I think there was partial attendance, particularly at the high schools as well as the primary schools. The religious gatherings, because Christianity is a big thing in our country, people could not go to church. So we had to make way around that. The retail outlets, shopping malls, after level 1 and 2, people were sick and tired. They just wanted to go shopping. So we had to respond to that. The funeral gatherings. I remember at some stage our city was on the news about the deaths and that we were not coping. It was not entirely true, but the funerals there were a lot of funerals that time. And we needed to make sure that during the funeral gatherings, with us, the traditional way of laying someone to rest, the family need to gather, there need to be an overnight, prayer, and the traveling of family members that are far, they need to be here. So there's often big gathering during funerals, various workplaces, and liquor establishments. Like said in the US, that there was a lot of liquor consumption. It was the same even here. We can proceed. So we monitored, because how you use premises can propel, or it had a potential to propel the spread of COVID-19. So we would identify the risk factors and effect control measures, effective management of cases and their contacts. So we then, in all the premises that we have identified, then created formalized groups where if there's a case at a particular retail store, then they would report to us as to what is it that they've done to make sure that they are decontaminating the premises and making sure that the premises were clean. So there was a lot of accountability that we wanted from the facilities. So in terms of the health surveillance of premises, we were doing some of the inspections ourselves, checking whether there was COVID-19 compliance as it was in the directives. For instance, the sanitizer at the door, the wearing of masks, the people in the shop not to exceed 50% of the floor area and so on. So we were physically doing those inspections and issuing warnings and notices where we found that there were areas of non-compliance. The old age homes, we had quite a number of cases from the frail care centers, and you know that group is a group that was at that time more at risk. The food establishment, the schools, as well as from funeral gatherings. If there was a funeral, we knew that we would then after that get quite a number of cases. So these are some of the cases that were reported to us by different schools. So we had established quite a good relationship with the schools within the city that we wanted them to report to us, and then we would follow with the investigation. Some of the cluster cases that we got, what we did is also we did contact tracing. Now, what we wanted to do to establish during contact tracing was whether there was any common factors between the cases, were they in the same gathering, what was the nature of the transmission in that setting. And these are some of the cluster cases that were found in different premises, and we would then, once we ascertain what the common cause was, we would then implement preventative measures, or rather corrective measures. We were also monitoring within the municipality itself, and this is just the number of positive cases that we got inside the institution. In fact, inside our directorate, because at the time it was only us, most people were work at home, so we were physically at the office. We did not get a lot of number of cases as expected. Now, we then did a surveillance program, partners with the MRC, the Research Institute, as well as this university. So the intention of the environmental health wastewater surveillance program is where we take water samples from the wastewater treatment plants to try and find the RNA samples. Now, what that would have assisted with was the early warning system, where we would then, because a person that contracted COVID would shed COVID RNA a week before they present symptoms. So we would then follow the trend or the cases through the wastewater. We wanted at the time when the program was introduced to be proactive and put preventative measures, go and warn that particular community well on time. But again, it did not really materialize as we had envisaged due to limited resources, and it was just a lot at some stage to really try and keep up with it. So these are all the wastewater treatment plants that we have in our city, and the number that we got, the number of copies per mil that we got when we did the analysis. And this is just the trend analysis of all the wastewater treatment plants. We then would see whether there was an increase in the number of cases as expected in a water treatment plant that is serving a particular community, or it was stable, and so on and so forth. This is what we did. And we are still continuing with this program even now. During contact tracing, we are liaising a lot with the Department of Health, because all the cases were reported at the clinics. And we then plotted the number of cases on a daily basis just to check how was the trend in our city. And what we had then found out at the time was that there was an inconsistent trend in our city. And when we did an investigation, it was mostly the youth that was gathering at the nightclubs, sneaking out, particularly in the Utenek area was very problematic. And we had quite big challenges in that regard. The sub-districts, our city, in terms of rendering of the health services, is divided into 3 sub-districts, the sub-district A, B, and C. So we then wanted to also see whether the challenge was sub-district A, sub-district B, or sub-district C. And we would then intensify the education in that particular sub-district if we found that a particular sub-district was more of a risk area. So this is just some of the cases that that were reported to us, and we had investigated and make sure that we put measures in place. These are some of the blitz operations. So blitz operation basically mean that we go out in a group, we educate, physical education. It was the most tiring time. So we did a lot of community education training and stakeholder engagement. We were everywhere. So those are some of the pictures of the awareness campaigns that we did, some of the focus groups that we've had, because there were a lot of questions like in Michigan, where you were getting, luckily you had a system where members of the public could phone in. Ours, we had to physically go out to the communities and educate them physically. So you can only imagine the amount of work that we had to do at that time. We were using different methods of communication, massive communication where we allowed hailing in communities, stakeholder engagement, like your councillors, your churches, your taxi bosses, anyone and everyone that you can think of, and one-on-one engagements, because when we were in the community members would come to us and approach us, how do I isolate? How do I, so there was that, a lot of that one-on-one engagement. Hazardous waste, what we then did during this time, because at that time people were wearing masks, and masks were becoming part of the general waste, because I mean, if you have COVID at home, how do you then dispose of the masks? We assisted some of the, particularly on level 1, because there wasn't a lot of cases, we could still manage certain things. We would assist a member with a box of masks if they were diagnosed positive, and we had a medical waste box that was placed in their premises, and then the boxes would be collected by a service provider that we contracted at the time. Because what we wanted is to reduce the risk as much as possible. We didn't want the masks to become a problem at the landfill sites. So we wanted to take that waste out of the mainstream waste. So we did that. I have to say, at some stage, it became a bit problematic because there were more cases. The demand was more than what we could supply. But thank God there was an introduction of cloth masks. And we then made sure that we educate the members of the public on the use of cloth masks instead of the surgical masks. So that alleviated a lot of the pressure. We were also doing surveillance at the hospitals, the clinics where some of COVID-19 patients were kept. So we had a stadium, the Nelson Mandela Stadium, because of the pressure in the healthcare system that could not cope. Some people that were not so sick, but needed some kind of medical attention were then sent to the stadium. There were doctors that were hired at the time. So we were also monitoring, making sure that we decontaminate. And one successful thing that I can say about the stadium was that not even one person died from the stadium. So there's something good that was done at the stadium. I'm not sure what it was because I was never there, but something was very good. This is part of the medical waste that came from the stadium. And we had to monitor the hazardous waste from the retail outlets because we know there's doctors and some of the retail stores like your Clicks and your ShopRite, they've got pharmacists. So we had to make sure that there are measures in place to deal with the waste that is contaminated with the virus. So those are all the chemists and public hospitals that we visited. We visited them 3 times a day, weekly, and the amount of quantities of waste that was collected, because we had to make sure that we keep that data up to date. The mortuaries, the management of human remains, we had to make sure, because there was a lot of deaths at that time. Often our mortuaries were packed, and sometimes the community members, they would bury 4 members consecutively. There wasn't any funds at some stage to bury, so the body would stay long. So we wanted to manage that situation where we make sure that the bodies do not stay long at the mortuaries. There was a constant burial of the deceased, and we needed to make sure that they were also having contracts in place to make sure that the waste was dealt with in a manner that would not cause harm to the members of the public. These are all the food production or the industry. We were monitoring the industry because some of them, they've got clinics on site. So we had to make sure that we are putting measures there. In terms of the mortuaries, currently in the city we've got 54, and all 54 were found compliant. We've got 2 crematoriums. The one is here in Gqeberha and the other one is in Dispatch. So both crematoriums were also found compliant at the time. And so both the crematoriums combined, they could handle the capacity of 900 bodies on a monthly basis. So what we did with the crematoriums, we wanted them to also send us statistics of the human remains that they cremated, and specify whether it was COVID related or it was not COVID related, because what we wanted to have was to build data and have statistics on the number of deaths that we had within our city. At the time that there was sensationalism on the number of deaths and how the municipality wasn't coping, there were groups that were pushing for the municipality to buy a bigger land of burial. So that is why we then decided, no, let us manage this area so that we don't go and purchase a land that is not going to be used. And all the cemeteries within our city, they were never full. I don't know where the news got that. So those are just the cremations that were done. We would track them on a monthly basis. These are all the cemeteries within our city, and we had to trace the capacity and the number of graves that were still available for the burial, so that we would then, if the graves were being limited, see whether then we needed to open new land, but there was really no need. If you look at Matanzima, this one, there was no land available at some stage. It was sitting at 0, but that graveyard was already full. It wasn't because of COVID. COVID might have just pushed the things onto the edge, but it was totally not COVID related that left that graveyard to 0. So in terms of the logistics, we did a lot of procurement, which we later got into trouble with. We had to buy surgical masks for the staff members that were doing contact tracing, particularly everyone. We had to buy the latest gloves, the disposable aprons, the coverall splash suit. So the contact tracing team had to wear the coveralls when they were going to the houses of people that had COVID, and we had sanitizer like crazy. The decontaminants, we bought chlorine solutions for decontaminating the households. the sprays, the foggers. We had everything. In terms of the medical waste, we also assisted in that regard, where we bought medical waste receptacles. Remember, at stage 1, we were still giving boxes to the members of the public to dispose of the contaminated masks. We also assisted because the mortuaries, as well as the government mortuaries, could not cope. We then procured a freezer container to store the bodies that could not be stored in the mortuaries at the government hospitals, the rental cars, we had interns which we rented cars for. So that's just some of the expenditure that we were sitting at the end of the 12-month period. But initially, when the whole COVID started, there was the whole budget of the departments was moved into COVID response, which that money kind of got lost in the way. And the COVID votes were then closed. So there wasn't any purchasing or any procurement in that regard. Colleagues, I think that's about it from my side. Thank you so much.
Thank you very much, Ms. Tembe. Any questions? Comments? Everything clear? Okay. We're going to have a slight change to the program because we are running a bit behind. So the presentation that is going to be done by Dr. Natalie will take place after lunch, together with the facilitated discussions, because I believe lunch is available. And you know, food safety, we don't want the temperatures to... Can we have a short lunch and then come back here at 2:30, please? Thank you very much. Enjoy your lunch. Good afternoon and again, everyone. Welcome back. Can I have your attention? There seems to be more people here than when we started. So for those that have joined us, welcome. I'm the chairperson for the second session. Cherise Brown is my name. And I have the pleasure to introduce to you Dr. Natalie Mansveld from the Social Development Professions Department here at the Nelson Mandela University. She will be presenting as well as facilitating some of the discussions that we will be having. I know our stomachs are full and it's the graveyard shift, but I'm excited for some of those discussions. And just to introduce Dr. Natalie to everyone, she's a social worker by education and worked in the field before turning to lecturing at the university. So I think one of our previous speakers indicated that it is a calling. For some of us, this was a calling. And I think after speaking to Dr. Mansveld, she's indicated that it definitely has been a calling for her. So she joined the university. And she's been working here for 10 years. In the Department of Social Development Professions, she teaches community development to third years and social justice and equality to second year students. Her research interests are around community development processes and the issue of student hunger at higher education institutions. So Dr. Natalie will now be presenting on the social issues and social determinants of health within the Nelson Mandela Bay. And we will then have some facilitated discussions. I believe it's between our environmental health students from social development professions, the Western Michigan University, as well as US Minnesota. Some of those students are here as well, am I correct? So interesting discussions that we will be having. So I now call on Dr. Natalie to come and present to us and enjoy the presentation. Thank you.
Thank you, Cherise, and good afternoon to everybody. As you might have seen on the program, I was supposed to present before lunch, but we did just had to alter the program, and I'm not really going to do a presentation. I think the facilitated discussions will be more valuable to you at this point to talk to one another rather than listen to somebody standing in front. So I just want to acknowledge, like Cherise said, that we have new people in the room now, and I want to really welcome them to this session. So there are 12 third-year social work students who have joined us. If you could just wave to us so that we see where you are, please. Okay, thank you. And then we have 11 students from St. John's and St. Benedict's in Minnesota, as well as their director, who's also joining us for this session. If you could wave as well, please. Okay. Right, so I think let us just get into our seats for the discussions before I do anything in front. So you would see that we've moved around some of the tables at the back. I would like to ask now that we have a representative of each of the 4 groups at each table. Okay, so if, for example, Western Michigan University, if you could go and sit one each at the 12 tables at the back. Then the same for the students from St. Ben's and St. John's, the same for environmental health, and you might be 2 students at some of the tables, and then the same for the social work students, 1 per table, please. Is everybody somewhat settled for now? Right, I think we're ready to start. Right, so the discussions are going to be structured according to the social determinants of health. Some of you may be very aware of it and others might not be very aware of it. I'll get back to that slide. But I just want to show you one of the models that's being used when one talks about social determinants of health. In other words, what are the things in society that contribute to people's health or lack thereof, is explained through the Dahlgren and Whitehead model. And what I like about this model is the fact that it talks about factors on 4 levels. That our health is firstly determined by our individual factors, so things like your gender, things like your age would impact on how healthy you are. We know we've had several connotations with age already this morning, and how that makes us relevant or not relevant, but in this case also could contribute to health or not so healthy. It could also be personal decision making. Things like, do I smoke or do I not? How much do I drink? And all of those things being part of the individual lifestyle factors. Then there's a second layer there called social and community networks, which is about your surroundings and what support you receive from the people around you, your family, your neighbors, the people in your community, whether there are networks there, groups who work together, or whether it is very unsupportive environments. Then the third layer, which is broken up there you see in small blocks, is about living and working conditions. And then there are 7 sub-blocks there. Agriculture and food production, education, work environment, unemployment, water and sanitation, healthcare services, and housing. So those are the more structural issues. And according to Dahlgren and Whitehead, the way your house looks and where your house is would also contribute to how healthy you are and how likely it is that you would stay healthy or not. And then the last layer in this model is the general socio-economic, cultural, and environmental conditions. So the broader ones that we don't have much control over, but it does impact on our lives. And then there is an interplay between all of these. If, for example, I smoke, but I live in a first world country, my other layers look very different from a person who smokes and lives in a third world country, right? And then those things interact with one another. So without me having to say this is how it works in South Africa and this is how it works where I come from, I've picked some of those, the second one from the outside, like education and work environment. I've picked some of those topics, and the idea is that I will give you certain questions and you will share with one another about that topic. The understanding is that no one of us can represent our country. So if somebody asks me, what is housing like in South Africa, I will most likely say what I've seen, what I know, where I've come from. But the person I'm speaking to must also understand that South Africa is so much more than Natalie Mansveld. So I can just give a limited view, but it's my view and my experience. So you are encouraged to do the same in your groups. You come from a certain context, you've already worked, whether it's practical work, volunteer work, anything else in a specific context, that have enabled you to see certain things, to make certain comparisons. And why we put people in groups the way they are is that we now have representatives from the US who have been in the country for a few days, and I believe I've seen quite a bit in those few days. Then we have people from the US who's been in the country for a few months. So they've seen a bit more, experienced a bit more over a longer time period. Then we have people locally who are from different disciplines, and they could be originally from rural or urban areas. They could be from here, they could be from a completely different part of South Africa. So we want to bring all of that diversity into your discussions and just sharing, this is what I've seen. This is what I've experienced. This is where I am from. And you can decide what you want to say and what you don't want to say. It's completely open-ended. Okay, so for now, don't worry about the pages and the cookies that have been put down. We'll get to that. But it's just about open sharing and learning from one another more than learning from one person standing in front and that person's limited experiences. So just to get you, I know some of you have already started introducing yourselves to one another, but there are 3 points there. The first one is I am. So you can choose how you finish I am. Some people would just say I am Natalie, and others would say I am so-and-so, and this is my age, and this is where I'm from, and this is what I like. That's you, okay? Share what you want to share to I am. Then the second one is my favorite food is, right? And if it's something that the rest of the group is not familiar with, you might just have to explain what you mean with that food. And then the last one, I am studying, whatever you are studying, because. Just something about why you are where you are now in terms of your studies. So I'm just going to give you about 3 minutes briefly for those introductions. Okay, so the first topic, according to Dahlgren and Whitehead's model, as one of the social determinants of health, is housing. Okay, so what I have on the slide is just one picture of an informal settlement in our country. And then I've just briefly stated there on the side that housing is a big issue for us in our country. We have a history of segregation, which I'm sure our visitors are aware of, where people from different race groups were, according to the laws of the country, not allowed to live in the same areas. And that has impacted then on certain areas, which were mostly then the white areas, where most of the resources went into, and you'll find your better type of housing there. But the rest of the race groups were neglected in terms of resources and where they were living, and so that led to many communities where housing does not look the same and is on the same standard. So here is another example, and we have multiple areas within our own city where it looks like this, where people have toilets that are outside of their homes. And you can see that people's homes are very close to one another, and there aren't formal roads, etc. And this has a lot of consequences for people. I was shocked the first time when I just realized things like, if people in this grey house in front, if a person in that house goes into labor in the middle of the night and calls the ambulance, it's not going to take 10 or 15 minutes for the ambulance to get there. Because firstly, to explain your address is quite something. And then for the ambulance to get to that house is quite something. And then we also have other social ills that play into that, like crime, which makes it even more difficult. But just in terms of what we can see there, the housing has an impact on other social issues as well. So my question to you in your group is, what are the different types of houses or shelters in your country? How do people acquire a house where you are from? And thirdly, how does a house enable or not health and wellness? So I'll give you 5 minutes for that in your groups. Okay, it's been 5 minutes. So I'm going to move us along, even if you're not done with the discussion, because some groups might be waiting and others are still talking. So it's okay if not everybody had the chance to share. Right. In terms of housing, this is just a picture that I personally like very much. It is a kind of an informal settlement type of house, but what people did here was they made it a double-story one. I have not been inside one of those to see how strong it is and whether I would be willing to sleep on the top story. But for me, it just says something amazing about the human spirit, about being able to do something over and beyond and make my life beautiful and interesting for myself. And that's just something that makes me believe in people and their resilience, despite their circumstances maybe not giving that impression when you look at it for the first time. Okay, then the second one is water and sanitation as another social determinant of health. And this has featured quite a bit in the presentations that we heard from the municipality as well as from the universities in this morning's presentations. But what I chose here was a picture of people who don't have access to water in their own homes. So people have to take buckets and go and queue to get water for the morning or for the day, if there is water available in the taps. But there is not always water, and I don't have to tell environmental health or public health students anything about health risks or anything associated to these. And then this was just an article in one of our local news outlets yesterday about a school in our city that is struggling with a sewage overspill. And Ms. Bly also talked about these things happening in our city from time to time. So just showing that it's happening right now as we are talking. And this is the conditions of people in terms of water and sanitation. And remember, our bigger conversation is how does this contribute to health and well-being? Right. So in your groups then, how do people access water where you are from? How likely are you to have clean water where you are from? And what would communities do if they don't have clean water? 5 minutes. Okay, we're not going to go through all 7 of the structural determinants of health. We just would not have enough time. Just selected some of them, but the third one is then healthcare. So the little bit of input from my side, and again, this was shared this morning as well, but we basically have 2 systems in our country when it comes to healthcare, and it's linked to our history again of apartheid and separate development. So we have private healthcare, which is high quality healthcare. It costs a lot of money if you don't have a medical aid. Medical aid is fairly expensive, but then people have peace of mind that the quality of healthcare is fairly good. The majority of the people in the country cannot access private healthcare because they cannot afford it. So there is healthcare available for them called government or public healthcare, but it is not on the same level. You can imagine now the number of people that need to access it is not the same as for private. So the number of resources that are required is on a different level. And unfortunately, we've not always had good management of all the public healthcare systems. So we often have newspaper articles about people who make court cases against some of our public health systems where they were treated unfairly or things went wrong that should not have gone wrong. So for various reasons, people are not always pro the public healthcare facilities, although there are some facilities that are really working well and where the staff are going over and beyond to serve the people of their community. And this is just a picture of people waiting in a healthcare center. And you can imagine now if somebody went there with flu or some sort of communicable disease, so sitting there for 3 or 4 or 5 hours, chances are things will spread there. And if you are not feeling good going there, I think sitting there for 5 hours is definitely not going to make you better. So this was an article also in one of the local newspapers yesterday, talking about the biggest local hospital that has now picked up that they have rats in some of their pipes. And they are talking about where is this coming from, what is the problem, and how can this be healthy at a public healthcare system. Okay, so questions. How do people access healthcare where you are from? How does medical aid work where you are from? And what are people's most common complaints regarding healthcare? Again, 5 minutes. So next one, I'm going to show you, but I'm not going to give time for discussions. But the next one, in terms of the order here, is education. So we have two departments in South Africa, government departments that are responsible for education, the Department of Basic Education and the Department of Higher Education. And the local students, obviously, as well as the students from St. John's and St. Ben's colleges would know that this past semester we at this institution have had a lot happening, that classes did not always take place the way it was planned and the way it was supposed to. And one of the reasons for that has been our transport system, the shuttle services of the university that has contributed a lot to disruptions because it has not always been available the way it should be. And that is also impacting on our session, that we cannot just continue until we are done because there are students who need to run to the shuttles, to be in line, to be able to get home before dark. Okay, so I'm not going to give you time to discuss education, but just wanted to highlight how that also impacts on our being together here and the way that we do our logistics. So I want to ask you now to use those white A3 pages that you've received and the markers, or the koki as you call it, in your group, and then just to write down on the one page some of the similarities that you heard in your discussions and some of the differences that came out while you were talking about housing, about water and sanitation, and about healthcare. Okay, doesn't have to be a long list, just some of those that stood out for you. What were the main differences and the main similarities between everybody's contributions within your group? Okay, I think you would have been done now with that last one. So, to wrap up these discussions, can we hear from one person in each group? You can share with us one thing that came out in your group that you found interesting. It can be a similarity, it can be a difference, it can be something else that somebody said that you found interesting. Okay. And if there's absolutely nobody in your group that found anything to be interesting, he said you're fired. Okay. I'm fired. All right. So, any person that would volunteer to go first? Right, we have a group here, so let's listen to people now instead of still thinking about what we're going to say or write. Yes?
I guess I'll stand up so people can give you the mic. That works properly. So one of the things that we determined was similar was we experienced different water contaminations, which I thought was really interesting. I'm from Michigan, where we have the Flint water crisis. So it's a lot different than what you guys experience here, but in a similar way, we all have that.
Okay, thank you. Next group.
Good day, everyone.
Okay, from my side, I think the interesting part. Okay, from my side, I think the interesting part was with regards to healthcare. So we've discovered that in the other countries, the private sector actually has a higher percentage than the public sector. So here in South Africa, private people are like 20%, and then public is like 80%. But with them, the private side is like 80%, and then the public side, it's like the list. So, and they also have better resources with regards to time frame. When you go to the hospital, you get a much better service, unlike South Africa. So yeah, thank you.
Thank you. Next group.
Okay. Do I have to stand? Okay. One of our similarities amongst all of us was that we all, for the most part, had access to tap water. The difference was that it may not all be drinkable. Like at home, I would drink out of the tap, like, and put it in a glass, whereas like here, you may not have the same like luxury, but we do all have access to tap water within or close to our house.
Okay, thank you.
Okay. I'll also touch on access to water and sanitation. So my group members mentioned that in the US they have access, like full access to water. And when they came here in Summerstrand, there were instances where some of them got sick because of the tap water and having to get water from the water truck and so on. And I also touched on how in my informal settlement that I currently live in, we don't have access to water. And the only time you get water is probably like 1 or 2 times a week, and you need to collect that in bulk. So that's a huge difference there. Another thing was in the US, you get good private and public healthcare systems, whereas here I was explaining a situation where I made an example of, let's say I want to get an abortion at a public clinic, and then the nurse comes and says, Lisa Kanya Fosi, here to do an abortion. Like, everyone knows I'm here to do an abortion, but that's supposed to be a confidential issue. And I know for sure the Health Professions Council doesn't allow that, but it still happens on a daily basis. And I explained also a situation where a rape victim was turned back from the hospital and told to go to the police station first, where they experienced trauma, and then she ended up dying, by the way. But yeah, so what else? Did I leave something out? Yeah, I think that's about it. Thank you.
That's a lot. Thank you. Yeah.
Okay, good afternoon, everyone. So I'm going to be speaking on the housing, 2 points of like the similarities and the difference. So something that was similar was that in South Africa we have the RDP housing, but then also in the US they have something called the Section 8, which is basically similar to the RDP housing. And then the difference was the security gates and that. So in South Africa, a lot of us have like, high walls and then the wire fencing and then like all sorts of security, the trolley dates, the dogs, whatever. And then in the US, I had mentioned how in a lot of like some of the areas, they don't even have like walls that you can go from the road to the pavement right to the door. So that was something that was like different for us. Yeah, thank you.
Thank you.
Okay. Our interesting part was the differences on the healthcare sector, differing in accessibility and also the quality of the services. We've discovered that in the US countries, they pay for their public services, whether you want medication or surgery or anything, they do pay. for us, we have public services. If maybe I have a headache or it's not something major, I can go to the clinic, I'm going to get help. Even though sometimes there are no doctors and nurses in the public hospitals and clinics, but we don't usually pay for the services that we used. What's interesting for them, there's also, I think you mentioned that if ever you've reached your limit within your health insurance, if you want to make a surgery or anything, you have to make an appointment maybe for next year. So if you're ill, you can wait and you've reached your limit within your health insurance, so you can just wait until next year or you can pay an extra amount. I think that's it. Thank you.
Okay, thank you. I'll first touch base on the similarities that we have found between the US and the SA. What we have found is that most departments are affiliated with politics, such as health, housing, and the other departments. And we have also found that private services, such as your medical aid and their medical scheme, as they call it, it's hard to access and it's expensive, and it's usually for those like that are on the first class. Then the differences that we have found is that their housing structure is more proper as compared to South Africa, and they have like easy access to water, whereas here in SA you'll have to struggle. Maybe sometimes you'll have to go fetch water from the river. And the public health care, the other difference that we have found is that they have like easy access to public health care, as compared to SA, whereas if you go to the clinic here, you'll have like to wait for longer hours to get medical attention. Thank you so much.
All right, I'm going to speak on the similarities we have. We mentioned language barriers within our healthcare system. So you have 12 official languages here in South Africa. And although English is ours, we often have some people who may be undocumented and speak Spanish and don't speak very good English. And then we also have people who don't read or speak above like a 5th grade level. So that may cause some language barriers as well.
Okay. In my group, we have some similarities. The first, we'll talk about the differences. Like when we come to the US, we see that we have more double-story buildings in order for them to save land. Then when you look at some of the things that stand up for my country, we don't have zoning system in my country. So if you carry our emails, you have to, the email people have to call you to the office to go and pick up your email because they don't have zoning system to find your house to to deliver your mails to you. We also, in my country, in Dallas, South Africa, we also have the same shelter houses in the informal setting. But what I see in South Africa from the picture, you people have a space between it. But ours, no, there is no space, so that when there's a fire, it can spread in the entire inn and bring the other people on down. Then we also see that water drop is more in South Africa. But in my country, we have a very high water table because we have 6 months of rain and 6 months of sun. So the water table is very high. But in the case, another thing that stand up here, in South Africa, we don't have no tap water business in my country. Everybody provide water for themselves. We don't pay water bills. So if you get your house, you put your own tanker up, you face your own well, you do your contamination of your water for yourself and everything. You don't depend on government for that. Also, we find out there's high water level in my country and also high water level in the US. So the similarity we see here that the private and public, we all have private and public hospital. But like in my country, we trust the private hospital than that of the government hospital. Because when you go there, you wait for long and you pay your money, they give you less treatment, so you should continue coming. So most people prefer to save that money and go to private health care and take treatment that will go up to a year before they could come back to the hospital. Thank you.
I think the biggest similarity is the one we looked at was like water quality. So in America, sometimes it sounds like, oh, we have clean water all the time. But especially in Michigan, that's not the case. We have a lot of, like Lexi said before, the Flint water crisis, there's a lot of lead in our water. So some places you may be able to drink straight out of the tap water, but other places you may not be able to. And we discussed that it's the same way in South Africa. Like some places the tap water tastes fine, and then other places you're not gonna wanna drink out of it. So I think that was the biggest similarity that we found. And the biggest difference was definitely in the healthcare system, as in America, like she said, nothing's free in America, and that goes with healthcare too. So you end up paying a lot for healthcare, and there's not a ton of government assistance when it comes to healthcare. There is some, but there's just not a ton like there is here.
Hi everyone. I'm not going to speak about differences and similarities, but just what was interesting to me. In the US, in India, we all have access technically to healthcare, but over there, you, like she said, you pay for everything. And then here, we are actually, how can I say, fortunate, because even though it's private and the public being bad, but in the public sector, everything is free, I guess. So it is more access from our side than to healthcare. So that was interesting. Yeah.
Any individual that still wants to say something, to share? Okay. Robin is the last one.
I just wanted to share that nothing in our about we were talking about like the difference between the US, but here in South Africa as well, just showing like how I was listening to the group speaking about the differences, but when they would say something about staying maybe in the rural area, from now the urban area, and so there was also differences between us as well, where I wasn't actually relating to anything that they were saying, even though we're both from South Africa. That was also something interesting for me.
Thanks, Robin. So I am always asking myself, so what? You've had this conversation, you've spoken about differences in countries and even within our own country differences, and then you go home and then so what, right? That's not something that I can answer for you. I can just tell you what I think the so what is. And for me, the value is that conversations like these with others about different situations helps me to understand my own situation. Because I often just think this is the way it is. But then I realize, oh, there could be differences, good or bad, but that also helps me to think as a professional, where and how could I contribute to improving things when I know there are different ways of doing things instead of just the way of doing things, because that's what I've always been used to. So I hope that through sharing and through listening to others, that somewhere something will stay behind to think, maybe we could rethink this where I am from. Maybe this does not have to be like this. Is there another way? Is there a better way? But that is up to you. It's not something that anybody in the group can tell you what that should be. So, Ms. Swanepoel suggested that as we end off, that perhaps in your groups, you could share contact details with one another. And if you never use it, fine. If at some stage you have an assignment and you need to compare with something of another country, you have a contact. Or if you really just want to keep in contact and learn more or engage in another way, then you would have the opportunity to do so. So I encourage you, just take it and then use it or don't use it, but then at least you have it. Okay. At this point then, I'm going to give back to Ms. Brown as the session facilitator.
Thank you so much, Dr. Netley. And I really want to, can we give Dr. Netley a round of applause for that? Excellent discussions. I think for the sake of time, and you've mentioned the shuttle situation happening, we're going to swap some items around oh, lights are following me everywhere. There's a reason why you need to be in a box, and I sometimes can't, I think outside of the box. So we're going to ask Mrs. Swanepoel to do our closing remark, and thereafter we'll do the group photo. I think, Anya, you want us to do the photo outside because it is raining. Okay, okay, yeah, due to the rain, we'll do it in the cafeteria. So thank you, Mrs. Swanepoel. Over to you.
Can I borrow your program? I get lost. Thank you very much. So we're closing, but we're not closing. We're closing, and then we're going to do a photo. I think I'm not going to try and do a huge intellectual summary of all of today's events. I think I just need to thank a few people specifically. So I want to thank our visitors from Western Michigan for reaching out to us with the help of Andre. Thank you very much for bringing your group of students to us. And a very, very big thank you to Sidlin, who's coordinated the event along with Natalie. Thank you, Sidlin. I think a lot of this has fallen on your shoulders. And then, yeah, so I think a big round of applause to Sidlin, first of all. And then to all of those who've had a role to play, to the colleagues here who facilitated sessions, to our team, Anya and Leah, and to Tembi, where's Tembi, who's been here all day and has organized teas and venues and all sorts. A very big thank you. So I hope I haven't missed anybody. Our visitors from Minnesota as well, thank you. And the STP students, thank you very much. Oh, goodness, yes. Tembi, to you guys from NMBM, thank you very much for your input into this. For me, it's been a very enjoyable day. I hope you found it to be that way as well. And I hope you'll take something with you as you go. So thank you very much, everybody. I think we can close the session. If you'll just bear with us so we can get a photo. Thanks. Thank you, everybody.